You may all please take your seats. We are starting the program now. Arogyam Bhaskar Abhivriddhiyartham. Health is for the rise of radiant sun within. A very pleasant and warm good morning to one and all. Our esteemed chief guest, Dr. Montu Kumar Patel, President, Pharmacy Council of India. Honorable Pro-Chancellor, Lieutenant General V.K. Sharma, recipient of Ati Vishisht Seva Medal. Our guest of honor, Dr. Deependra Singh, Chairman, Education Regulation Committee, Pharmacy Council of India. Respected officiating Vice Chancellor, Professor Dr. Anil Vashisht, Director, Amity Institute of Pharmacy, Professor Dr. S. Mohana Lakshmi, respected dignitaries, registrars, deans, directors, head of institutes, head of departments, faculty members, staff members, and our valued delegates and dear students. I, Roshni,
and I, Palak, extend a hearty welcome to the two-day National Conference on Cardiovascular Diseases, Prevention, Management, and Treatment, organized by Amity Institute of Pharmacy, Amity University, Madhya Pradesh.
Vyayamat labhate swasthayam, dirghayusham balam sukham, arogyam paramam bhagyam, swasthayam sarvartha sadhanam. Exercise is beneficial for health, longevity, and strength. Health is the ultimate good fortune. Health is for all means of purposes in life. It is commonly said that your genetics load the gun, but it's your lifestyle that pulls the trigger. And since the last decade, human beings have embraced the habits which lead to these new disorders called lifestyle disorders that are also called as non-communicable diseases.
Today, we aim to shed light on the importance of proactive measures in safeguarding against cardiovascular diseases, which remain a leading cause of mortality worldwide. The deliberation of this conference will explore lifestyle modifications to medical interventions and the array of tools present at our disposal.
So let's embark on this journey together as we empower ourselves and our patients to take charge of their own cardiovascular well-being. Amity Institute of Pharmacy welcomes you all to the discussion on cardiovascular diseases, prevention, management, and treatment.
I request our Honorable Pro-Chancellor to welcome the guest of honor, Dr. Deependra Singh. Sir, please. Thank you, sir. I now request our Honorable Pro-Chancellor to welcome our keynote speaker, Dr. Ratinder Jaj. Sir, please. Thank you, sir. Thank you, ma'am.
I would like to invite the Director, Amity Institute of Pharmacy, to welcome our Honorable Pro-Chancellor. Ma'am, please. Thank you, ma'am. Thank you, sir. I would now like to request Director, Amity Institute of Pharmacy, to welcome our officiating Vice Chancellor. Ma'am, please. Thank you, ma'am. Thank you, sir. Moving ahead towards the conference, let's take blessings of Goddess Saraswati by lighting the torch of wisdom and understanding in order to make this morning fortunate. I invite all the dignitaries to kindly kindle the ceremonial lamp.
Thank you, dignitaries. We now request them to take their respective seats on the dais. We'd now like to invite the Director, Amity Institute of Pharmacy, Professor Dr. S. Mona Lakshmi, for her welcome address. Ma'am, please.
Good morning to all. The chief guest of today's occasion, the Honorable President, Pharmacy Council of India, Dr. Montu Patel, Honorable Pro-Chancellor of Amity University, Madhya Pradesh, Lieutenant General V.K. Sharma, Ati Vashist Seva Medal, Honorable Guest of Honor for the occasion, Dr. Deepender Singh, Chairman, Education Regulatory Commission, Pharmacy Council of India, Officiating Vice Chancellor of Amity University, Madhya Pradesh, Dr. Anil Vashist, the keynote speakers for today's conference, Dr. Punit Rastogi, Head of the Department of Cardiology, Gajraraja Medical College, Gwalior, Dr. Ratinder Jaj, Head of the Department of Pharmacology, All India Institute of Medical Sciences, Bhopal, heads of various pharmacy institutions, delegates, participants, faculty members, staffs, and my dear students. Greetings and namaskar to all of you. It is with great pleasure and honor I welcome you all to the Amity University, Madhya Pradesh for this 2 days national conference on cardiovascular diseases, prevention, management, and treatment. Ladies and gentlemen, we all are well aware the thoughts that arises in our mind, it may be a positive thought or it may be a negative thought. They are not just vibrations in the air. The thoughts that arises in our brain are not just vibrations in the air. They are well-defined electrochemical events with physiological consequences. Thoughts in the brain are converted into matter, and this disseminates into each and every cell in our body. The thoughts that arises disseminates in almost 30 to 40 trillion cells in our body in the form of neuropeptides. If our thoughts are distressing, full of worries, anger, anxiety, ego, so what will happen? It will pour the stress hormones into our body and it will burden our heart. And this will lead to coronary artery diseases. If we can reverse this process by creating an environment of positive thoughts, happy environment, peace, this can minimize the load on the heart, which should lead to the reversal of these kind of diseases. Therefore, we understand the key is prevention. Ladies and gentlemen, on this occasion, I just want to share an incident which happened in 1929. The incident which happened in 1929, which pushed the boundaries of medicine into a new era and opened the doors of today's modern cardiology. So in 1929, a 25-year-old surgical intern, a young 25-year-old surgical intern of Germany, he used to do a lot of self-experiments to conquer the heart. So one day, what he did, he anesthetized his own arm. And he tried to pull a urinary catheter into one of the veins. And he advanced that catheter further, and he found, with the help of fluoroscopy, the catheter reached his shoulder. Then he further advanced this catheter into the full length of the catheter of 60 centimeter. And with that, he ran into the X-ray room and he captured that in the X-ray film, and he found the catheter is in the right atrium of his heart. So he has two objectives. The first objective is to study the heart for the diagnosis, and the second objective is to administer drug directly into the heart. So his bold experiment was one of the bizarre in the medical history. He published his findings in many leading journals in the Germany, and it also entered into the annals of thoracic surgery. So even though there is a lot of controversies, there is a lot of disagreements on these findings, but he received the Nobel Prize for this finding in 1956. His daring experiment laid the foundation for today's modern cardiology. With this small information, I once again welcome you all for the National Conference in Cardiovascular Diseases. Over the next few days, we will engage in rich discussions, meaningful presentations, and collaborative efforts that span cardiovascular science, pharmacology, and research. I would like to express my gratitude to all the dignitaries on the dais, esteemed speakers, session chairs, CPR team, delegates, participants, and students. Your passion, expertise, and commitment to this cause are the driving force that will make us to move forward. Let us approach the next 2 days with open minds, collaborative spirits, and a shared determination to make a tangible difference. Together we can and will forge a better, healthier future. Thank you one and all. Wish you best of luck. May God bless you all.
Thank you, ma'am, for your highly welcoming and motivating words. Now I would like to invite Honorable Pro-Chancellor to present his opening remarks on this event. Sir, please.
Very good morning to all of you. So Dr. Ratendra Jha, HOD of Pharmacology, AIIMS, Bhopal. Dr. Dipender Singh, the Chairman of Education Regulatory Commission, Pharmacy Council of India, Dr. Anil Vishisht, officiating Vice Chancellor, Amity University of Madhya Pradesh, Dr. S. Mohana Lakshmi, the Principal and HOI of Amity Institute of Pharmacy, the delegates, participants, and all the students who are sitting here. The topic for today's national seminar, Cardiovascular Diseases Prevention, Management and Treatment, is apt for the day today because we find that heart attacks are happening not only to the aged, but young people also. We find that young people dancing on the floor are suddenly collapsing. We also find that there's so much of stress and tension that it is leading to failure of heart or cardiological diseases at too small age, which has not been happening earlier. This trend is indeed a worrying trend. Now, why is our youth becoming prone to such diseases like cardiovascular diseases? Why it is happening and what is it that we can do about it today? Primarily, the heart is an organ, which functions throughout 24/7, right from the moment we are born till we die. And it pumps millions of gallons of blood in our body, and the whole system of a living being is maintained by the function of the heart. The importance of the heart, everybody well understands. Now, prevention is always better than cure, is a normal saying. And let us concentrate what we can do to prevent heart disease. First and foremost is the food and the eating habits. All food which does not contain cholesterol is preferred food. And remember, cholesterol is produced only in animals. All plant foods do not have cholesterol. Cashew nuts, they are product of plants, so zero cholesterol. Almonds, product of plants, so zero cholesterol. Cholesterol basically is produced in the human body itself, which is required to a certain extent. Not all cholesterol is bad. Some cholesterol is required to perform certain functions. But in the animal food or any product of animals, the cholesterol is a damaging factor if it is in excess. The saturated fats, trans fats, if consumed in excess, are bad. All sugars leading to diabetics or even marginally high blood sugar maintained during normal day is bad. Consumption of tobacco, which youth do for style, to show off, but the amount of damage it does is bad. And more damage is caused by all these habits in youth. Why? Because your systems get adapted to the change very fast. Remember, all the young people who are sitting here, your systems are raw. So therefore, they get attacked by any such agents very fast. Alcohol, which will not have much effect on aged people, but on young people, it has got so much of effect because your system has not got used to it. Similarly, any such things which your system is not used to get used to it, you get attacked very fast. So therefore, the effect on youth on bad food habits is more than on adults. So therefore, you should be careful not to have healthy food habits. One. Second prevention method is hurry and worry. Hurry and worry. Worrying does not solve any problem. No problem has been solved by worry alone. There's a difference between thinking and between worrying. Thinking is good. You're thinking something. You're trying to find solution to a problem. That's a good habit, nothing wrong. But the problem is when you start worrying, something that you wanted to happen, an outcome, that outcome has not happened, then you start worrying. What if? What if this thing does not happen? What if I've done a mistake if my parents come to know about it? What if I've stolen something and people find it out? What if? This what if tendency is what causes worry. And by worrying, your heart rate goes up. You spend sleepless nights. Lack of sleep is another thing which results in heart diseases. You proper rest is very much required, and hurry, trying to do everything in a hurry. You are moving from one place to other. You are not able to manage this stress and tension. Remember, stress and tension to a certain extent is very much required to progress in life. To think of somebody leading a life without any stress or without any tension is unthinkable in today's world. It's a competitive world after all. You got to compete to get good marks. You got to compete to get a good job. You got to compete in your class, in your sports field. Everywhere there's competition. But the difference is the competition should be a healthy competition, and you should be in competition with yourself. Try to become a good human being. Try to become a good person. Try to get better marks than you got last time. If you are in competition with yourself, you will find that you will automatically be competing with the world. You don't have to compete with individuals. And most importantly, manage stress. Manage stress. Learn how to cope up with stress. Keep your mental activity at a lower level and try to manage stress. Yoga and meditation is an excellent way to manage stress. Yoga keeps your blood circulation going, and the mantra of staying healthy is through ensuring that you get enough oxygen and you get enough blood circulation. We all eat food. Most of us who are sitting here come from good families, and we don't have to worry about next meal. We are sure that we are going to get it. There's no worry on that. But what we don't get is enough oxygen to burn that food. Most of the food contains carbon and hydrogen and nitrogen. All these require something called oxygen, which is available free today in the atmosphere. The oxygen will break down these into carbon dioxide, water, nitrogen oxide, etc. And that the energy which you get after that, which is, these are all exothermic reactions, that is metabolism. So metabolism, the process of converting food into energy, is something very important, and for that you need oxygen, and best way of getting oxygen is through exercise. Exercise well. Maintain a control on your weight. Ensure that you do not become obese. Eat only that much which is required by you. Eat healthy food. So some of the lifestyle, if you ensure proper lifestyle, if you ensure that you are doing adequate exercise, if you ensure that you are able to manage stress, then you will not be affected by any heart disease. Unless, of course, 0.1% chances if something is hereditary or which is there given through the genes, that is different. But those are very less cases, and even those cases can be managed. So therefore, it is important to prevent cardiovascular diseases, which is very much possible by managing the lifestyle, by doing proper exercise, maintaining a healthy routine, healthy food habits, and working and not having undue stress and undue tensions in life. Monitoring, I think for the age people who are less than 50 years, it is recommended that ECG once in 2 years is good enough, which will tell you that your heart is quite fine. And after the age of 50 years, once a year, ECG is recommended. That is the only test, I think, which should be there undertaken by all of us. Otherwise, milk products in particular today, milk is something which is being produced to animals, and the production of milk, if done through animals, is limited. It is not unlimited. But today you ask your milkman, if you are taking 1 kg every day, you ask him that tomorrow I want 10 kgs, he'll produce 10 kgs and give it to you. From where will he get the 9 kgs? The cows are, the buffalo is not going to produce more milk because you asked for it. So he'll give you artificial milk, or he will give you adulterated milk. So milk products, particularly today, which are available in the market, including some of the packaged foods, they contain, it has been found, if you get them tested, they are adulterated. So such foods taken from sources which are not authentic also lead to problems. And of course, there are preventive measures, there are treatments available, which the experts will talk about who are sitting here. But I would like to tell you all, suffice that if you take away from today to eat healthy, to live healthy, and to live tension-free and stress-free, and to learn how to manage stress, I think then you will find that you are not in the category of heart disease and cardiovascular, and you will lead a good and healthy life. Wish you all the very best. Thank you very much. Jai Hind.
Thank you, sir. I believe your words will inspire everyone.
I extend a hearty welcome to Dr. Montu Kumar Patel, Honorable President of Pharmacy Council of India, who is joined online. A hearty welcome to you, sir.
Sir, we are so blessed to have your presence.
Please welcome Dr. Puneet Rastogi. May I please request you all to please welcome Dr. Puneet Rastogi.
I'd like to request our officiating Vice Chancellor, sir, to please welcome Dr. Puneet Rastogi. Thank you, sir. Sir, we are so blessed to have your presence. Dr. Montu Kumar Patel, sir.
Hello.
So I'd like to request you to grace the occasion with your words of wisdom. Sir, please.
हेलो, आवाज आ रही है मेरी?
Yes, sir.
ओके. Can I start, madam?
Yes, sir.
Sure, sir.
हाँ, नमस्कार.
Montu Kumar Patel, sir, I extend a hearty welcome to you on behalf of MIT University, Madhya Pradesh.
Yes, sir. नमस्कार, नमस्कार.
Thank you very much for joining.
Can I start my speech or after later sometime?
सर आप प्लीज स्टार्ट कर सकते हैं.
Okay. नमस्कार. Thank you for inviting me in the MIT University for the National Conference on Cardiovascular Disease Prevention, Management and the Treatment. MIT यूनिवर्सिटी के वाइस चांसलर, रजिस्ट्रार और इस कॉन्फ्रेंस के ऑर्गेनाइजर सभी लोगों का मैं धन्यवाद देता हूं, और इस फंक्शन के चीफ पैट्रन ऑनरेबल असीम चौहान जी, ऑनरेबल जनरल ऑनरेबल वीके शर्मा जी, डॉक्टर अनिल वशिष्ठ जी और प्रोफेसर MB कौशिक जी. जो टॉपिक है बेसिकली हमारे फार्मासिस्ट का, जैसे कार्डियोवास्कुलर डिजीज का प्रिवेंशन, मैनेजमेंट एंड ट्रीटमेंट. अभी तो आपको पता है कि पूरे इंडिया में अभी CPR का बहुत ही बड़ा रन, मतलब बहुत बड़ी ड्राइव भारत सरकार ने और स्टेट गवर्नमेंट में चलाई कि कैसे हमको इमरजेंसी सिचुएशन में CPR देकर हम बचा सकते हैं. लेकिन ये तो सरकार ने ड्राइव रन की और हमने किया, लेकिन हमारे फार्मासिस्ट का जो रोल है कि इमरजेंसी सिचुएशन हो तो उसमें कैसे प्राइमरी ट्रीटमेंट मिले, और प्राइमरी ट्रीटमेंट की जितनी भी, चाहे चाहे अपना कोई स्नेक बाइट हो, या तो कोई इमरजेंसी में कोई एक्सीडेंट हो, या तो मतलब बहुत सारी जो इमरजेंसी सिचुएशन डे टू डे में होती है, उसमें फार्मासिस्ट का रोल क्या होना चाहिए. और जो क्रोनिक डिजीज है, जैसे कार्डियोवास्कुलर डिजीज है, किडनी के डिजीज है, लीवर के डिजीज है, जैसे क्रोनिक डिजीज है जो बहुत ही लंबे समय तक चलते हैं, और उसको मैनेजमेंट और उसका ट्रीटमेंट कैसे किया जाए. क्योंकि आज के दिन में, मतलब आज के समय में, जब से ज्यादा जो एंटी माइक्रोबियल रेजिस्टेंस की वजह से बहुत ही सारे जो डिसीज है उनमें बहुत ही हायर एंटीबायोटिक्स जो इफेक्ट्स है, वो भी उनकी जो पोटेंसी है वो मतलब उनका असर करना छोड़ दिए, और हाईएस्ट जो डेथ है वो एंटी माइक्रोबियल रेजिस्टेंस से हो रहे हैं. तो बहुत सारा जहाँ पे हमारे फार्मासिस्ट का रोल है और हमने अभी इतने सालों में कभी किया नहीं है. बात करें कि फार्मेसी काउंसिल ऑफ इंडिया ने क्या क्या काम किया, क्योंकि मैं शुरुआत से बोलूंगा, क्योंकि आपको पता है कि फार्मेसी काउंसिल ऑफ इंडिया एक फार्मेसी एजुकेशन और फार्मेसी प्रोफेशन दोनों को रेगुलेट करती है। लेकिन अभी तक फार्मेसी काउंसिल ऑफ इंडिया में हमने सिर्फ एजुकेशन ही रेगुलेशन किया, प्रोफेशन को कभी रेगुलेशन करने का प्रयत्न ही नहीं किया। तो अभी बहुत सारे जो हमारे अनरिजॉल्व इश्यू बहुत साले पुराने थे, जैसे आपको पता है कि 5 तारीख को हमने जो जीपेट एग्जामिनेशन का है उसका भी हमने एक इस साल हम नेशनल बोर्ड ऑफ एग्जामिनेशन द्वारा हम लेने जा रहे हैं, और जो लास्ट ईयर बच्चे जो पास आउट हुए उनको हम जीपेट का स्टाइपेंड हमारे फार्मेसी काउंसिल इंडिया का सेल्फ जनरेटेड फंड से हम देना शुरू किया है। इसमें भी क्योंकि फार्मेसी काउंसिल इंडिया के पास कोई इतना बड़ा फंड नहीं था जब मैंने चार्ज लिया तब कि हम किसी को स्टाइपेंड या तो स्कॉलरशिप दे सके, लेकिन लास्ट 2 साल में आपको पता है कि हमने फार्मेसी काउंसिल ऑफ इंडिया ने सारी फार्मेसी इंस्टीट्यूशन की फीस भी इंक्रीज की। फीस इसीलिए इंक्रीज की कि बच्चे सारे इंस्टीट्यूशन कमा ही रहे हैं, सब अच्छे बच्चे और अच्छी इंस्टीट्यूशन अच्छी तरह काम करके अपनी रेपुटेशन भी बना रहे हैं। लेकिन जो फार्मासिस्ट की रेपुटेशन है, तो फार्मासिस्ट के जो प्रॉब्लम्स है उसको रिजोल्व करने के लिए फार्मेसी काउंसिल इंडिया को फंड चाहिए। तो हमने जो हमारा फीस है वो थोड़ा बढ़ा है, और काउंसिल के पास सेल्फ फंड और सेल्फ सस्टेनेबल काउंसिल हमने बनाई। और इस साल हमने इस लास्ट ईयर के लिए 50 करोड़ का बजट जीपेट स्कॉलरशिप के लिए, और आने वाले समय में मैक्सिमम 150 CR से प्लस बजट हमने जीपेट स्टाइपेंड के लिए हमने एलोकेट किया है। तो आप देख सकते हो कि जो 2 साल का जो हमारा ट्रांजेक्शन पीरियड है उसमें बहुत सारी फार्मेसी इंस्टीट्यूशन से हमने, बहुत सारे लोग हमारे सामने कोर्ट में भी गए, बहुत सारे हमारे ऑपोजिशन के लोग अननेसेसरी लोगों को गैर मार्ग के दौर कर काउंसिल के सामने एजिटेशन भी करवाया। लेकिन जो भी काउंसिल ने काम किया है वो फार्मासिस्ट और टीचर्स के मतलब फेवर में किया है। अभी जितनी भी एआईसीटी स्कीम्स देती थी, आपको पता है कि मोर ड्रॉप हो, रिसर्च की स्कीम हो, या तो इंडस्ट्री ट्रेनिंग की हो, टीचर ट्रेनिंग की हो, वो सारी स्कीम भी मतलब फार्मेसी काउंसिल ऑफ इंडिया ने उसके लिए बजट एलोकेट किया है। वो भी मतलब विद इन 2 मंथ्स हम उसके लिए भी सर्कुलर निकालेंगे, और सारे फार्मासिस्ट और टीचर्स और स्टूडेंट दोनों ये सारी ग्रांट के लिए अप्लाई कर सकेंगे। और आने वाले समय में जितने भी ज्यादा से ज्यादा टीचर और स्टूडेंट को रिसर्च ग्रांट मिले, इंडस्ट्री की ट्रेनिंग करने के लिए ग्रांट मिले, मतलब सारा प्रोविजन हमारे फार्मेसी काउंसिल ऑफ इंडिया की काउंसिल मतलब हमारी ऑफिस से किया हुआ है। बात करते हैं एग्जिट एग्जाम, क्योंकि एग्जिट एग्जाम बहुत सालों से गैजेट तो हो गया था पर उसको इम्प्लीमेंटेशन का पार्ट कोई नहीं कर रहा था, क्योंकि इम्प्लीमेंटेशन में, क्योंकि कायदा कानून बनाना तो आसान है पर उसका इम्प्लीमेंटेशन पार्ट है वो बहुत ही डिफिकल्ट है। क्योंकि पूरे इंडिया से जो लोग, आपको पता ही है कि वैसे ही जो नॉन अटेंडिंग डिप्लोमा कॉलेज चला रहे, जो मतलब ऐसे ही थोड़ा माल प्रैक्टिस कर रहे हैं, उन लोगों को तो ज्यादा दिक्कत होगी। फिर भी हमने उन लोगों का एजिटेशन, उन लोगों का पॉलिटिकल कनेक्शन होने के बावजूद भी हमने ये एग्जिट एग्जामिनेशन का इम्प्लीमेंटेशन करवाया, क्योंकि इतने सालों से नहीं होने का कारण भी एक बहुत ही बड़े लोग उसके पीछे थे, और उन सबको हमने कंट्रोल करके हमने एग्जिट एग्जाम का इसी साल से इम्प्लीमेंट करवाया। तो आने वाले समय में डिप्लोमा के बच्चे अब क्वालिटी एजुकेशन लेकर क्वालिटी प्रैक्टिस करेंगे और गुड प्रैक्टिस करेंगे डिस्पेंसिंग की। वैसे ही अब आने वाले समय में एक बार डिप्लोमा का हो जाए तो आने वाले समय में बैचलर के लिए भी कैसे हम कर सके उसके लिए भी हम प्लानिंग करेंगे। दूसरा कि हमने, जैसे आपको पता है कि ये सारी जो कॉन्फ्रेंस होती है उसके लिए कहीं ना कहीं एक्सपेंस होता है, चाहे यूनिवर्सिटी का हो चाहे बच्चों का हो, चाहे रिसर्च जितने भी लेक्चर लेने आते हैं उनको भी हमको बहुत ही मतलब उनको चार्ज देना पड़ता है। तो ऐसी कॉन्फ्रेंस के लिए भी फार्मेसी काउंसिल ऑफ इंडिया ने बजट का प्रोविजन किया है कि जो इंटरनेशनल की जो कॉन्फ्रेंस होगी, अगर कोई यूनिवर्सिटी या तो इंस्टीट्यूशन अप्लाई करता है तो उसके लिए हम 2 लाख का बजट एलोकेट किया है, और अगर कोई स्टेट लेवल की कॉन्फ्रेंस होगी तो उसके लिए 1 लाख का बजट का हमने प्रोविजन किया है। तो ये भी हम इम्प्लीमेंट करने जा रहे हैं, और सारे फार्मेसी इंस्टीट्यूशन को भी इससे फायदा होगा, और उनकी जो रैंकिंग और एक्रेडिटेशन में जो पॉइंट्स मिलते हैं इसके, उसमें भी उनको बेनिफिट होगा। तो ये सारा काम फार्मेसी इंस्टीट्यूशन, बच्चे मतलब फार्मेसी के स्टूडेंट्स और टीचर्स तीनों की फेवर में जो भी बजट हमारी फार्मेसी काउंसिल इंडिया में फीस का आता है उससे मैक्सिमम उसका यूटिलाइजेशन पब्लिक के लिए कैसे किया जाए वो हमारी काउंसिल प्लान कर रही है। और क्योंकि पता है कि फार्मेसी काउंसिल ऑफ इंडिया फार्मासिस्ट की काउंसिल है, हम सबकी काउंसिल है, तो हम सब एक ही जगह पे बैठे हैं, तो हम फार्मेसी प्रोफेशन के लिए कैसे काम करे वो हमको सोचना है। क्योंकि मैंने पहले ही बोला कि अभी तक लोगों ने एजुकेशन के लिए काम किया था पर फार्मेसी प्रोफेशन के लिए कभी किसी ने काम नहीं किया था। बात करते हैं कि सारे बच्चे अभी पढ़ रहे हो गया तो एमफार्म में हो गया तो कोई रिसर्च स्कॉलर होगा, तो नया पोर्टल हमने इसी साल बनाया, उसके लिए भी बहुत बड़ा हमने बजट का प्रोविजन किया है कि सारा जो है मतलब हमारा पोर्टल वो आधार कार्ड और के साथ लिंकअप होने वाला है। और जितने भी स्टूडेंट पढ़ रहे हैं वो सारा हमारे फार्मेसी काउंसिल के पोर्टल पे स्टूडेंट रजिस्ट्रेशन में वो रजिस्ट्रेशन इसी साल से शुरू हो गया। और जब भी वो पास आउट करेंगे और स्टेट काउंसिल सिलेक्ट करेंगे तो डायरेक्टली वो स्टेट काउंसिल में उनका रजिस्ट्रेशन का डॉक्यूमेंट पहुंच जाएगा और स्टेट काउंसिल उनको सीधा ही रजिस्ट्रेशन ग्रांट कर देगी। तो ये सिस्टम भी सिंगल विंडो रजिस्ट्रेशन सिस्टम भी हमने इसी साल से इम्प्लीमेंट कर दिया है कि जो भी बच्चे पढ़ रहे हैं उन सबको जब भी पास आउट होगा इस साल से उन सबको ये बेनिफिट मिलना शुरू हो जाएगा। वैसे ही टीचर्स के लिए भी हमने सारे टीचर्स को भी आधार कार्ड के साथ लिंकअप करना शुरू कर दिया है। और हमने सेंट्रल काउंसिल का रजिस्ट्रेशन नंबर दिया है जो बीएच से शुरू होता है, क्योंकि बहुत सारे टीचर्स बहुत जगह पे काम नहीं करते और दिखा देते, उससे हमारे जो डुप्लीकेसी थी डेटा में या तो जो माल प्रैक्टिस जहाँ चल रही थी वो भी इसी साल से बंद होना शुरू हो जाएगी। और जो पोर्टल है हमारा जितने भी इंस्टीट्यूशन की फैसिलिटीज है, चाहे इंस्ट्रूमेंट हो, चाहे बुक्स हो, चाहे क्लासरूम हो, चाहे लेबोरेटरी हो, सबको हमने गूगल टैग के साथ और क्यूआर कोड के साथ हमने लिंकअप किया है। तो जब भी इंस्पेक्शन होगा तो सारा पूरा लिंक स्कैन हो जाएगा और एक मतलब विदाउट इंस्पेक्टर के इंटरफेयर ये हमारा इंस्पेक्शन रिपोर्ट जनरेट होगा और क्वालिटी एजुकेशन जो इंस्टीट्यूशन दे रहे हैं उनको बेनिफिट मिलेगा। और जो भी इंस्पेक्टर है वो कुछ भी रिपोर्ट में कुछ भी ऐड ऑन है तो डिलीट ऑन कुछ भी बिना सिस्टम के कर ही नहीं पाएगा। अभी क्वालिटी काउंसिल ऑफ इंडिया के साथ भी फार्मेसी काउंसिल ऑफ इंडिया ने एक एमओयू साइन किया है जिससे फार्मेसी की जितने भी भारत देश में, क्योंकि आपको पता है कि अगर हम फॉरेन कंट्री में सर्च करते हैं कि अच्छे इंस्टीट्यूशन वो कंट्री में कितनी है तो हमको एक लिस्ट आ जाता है, लेकिन भारत देश में हमको कोई लिस्टाइज करे भी भारत में कौन से स्टेट में कितनी अच्छी इंस्टीट्यूशन है या तो पूरे देश भर में टॉप 100 इंस्टीट्यूशन कितनी है वो किसी को भी आज आज के दिन में पता नहीं है। मतलब 5-10 इंस्टीट्यूशन का नाम सबको पता होगा पर टॉप 100 टॉप 1000 कितनी है वो भी किसी को पता नहीं है। उसके लिए हमने इनिशिएशन शुरू किया है कि क्वालिटी काउंसिल ऑफ इंडिया के साथ रैंकिंग एंड रेटिंग, मतलब जितनी भी फार्मेसी इंस्टीट्यूशन है पूरे इंडिया में उसका रेटिंग और रैंकिंग फार्मेसी काउंसिल इंडिया ही करवाएगी और उसके हिसाब से उनको अप्रूवल भी मिलेगी फ्यूचर में। तो एक क्वालिटी एजुकेशन जो संस्थाएं देती होगी जैसे एमआईटी यूनिवर्सिटी है उनका जो एक एक इमेज है वो काउंसिल के सामने अलग होगा और पूरे वर्ल्ड में भी उनकी इमेज जो टॉप 10 में आएंगे तो टॉप 100 में आएंगे उस हिसाब से उनका रैंकिंग हो जाएगा। तो फॉरेन के जो बच्चे इंडिया में आके पढ़ाई करना चाहते हैं उसके लिए भी एक नया स्कोप ओपन हो जाएगा। और फार्मेसी इंस्टीट्यूशन या तो फार्मेसी की जितने भी यूनिवर्सिटी के डिपार्टमेंट्स है उनको भी फॉरेन के बच्चे मिलना शुरू हो जाएंगे। और जो हमारा विजन है हमारे ऑनरेबल प्राइम मिनिस्टर का जी का कि हमारे फार्मेसी के पास इतना वर्क फोर्स है, जो फार्मासिस्ट इतने वर्क फोर्स है तो पूरे देश भर में जाके काम करे और हमारी जो फार्मेसी की शिक्षा है वो देश भर से लोग इंडिया में आके ले और वहां पे जाके काम करें। ये पूरा ही मतलब एक अच्छा विजन लेकर हम काम कर रहे हैं। और जैसे बताया कि एक बहुत ही 75 साल में हमारे से एक टॉपिक छूट गया है, क्योंकि आज का जो टॉपिक है इससे रिलेटेड है कि हमने बहुत सारे डिजीज पे हम काम करते हैं, इंडिविजुअली कॉन्फ्रेंस करवाते हैं, कॉन्फ्रेंस करवाने के साथ हम उनको अच्छा नॉलेज भी देते हैं। लेकिन ये नॉलेज अप्लाई कहाँ पे होगा, मतलब आपने चलो कार्डियोवास्कुलर डिजीज का प्रिवेंशन मैनेजमेंट एंड ट्रीटमेंट आपने उसका डिजीज क्या है, मेडिसिन क्या आएगी और आने वाले समय में क्या रिसर्च हो रहा है पूरा हम डिस्कस तो करेंगे, पर इसका बेनिफिट कैसे मिलेगा क्योंकि हमारे फार्मासिस्ट तो प्रैक्टिसिंग कर ही नहीं रहे। मतलब हम कोई भी मतलब कोई भी आदमी का या तो कोई भी पॉपुलेशन जो इंडिया की है, हम सिंगल पेशेंट काउंसलिंग नहीं कर रहे। मतलब पेशेंट का कोई भी हम पेशेंट काउंसलिंग कर ही नहीं रहे, तो ये नॉलेज लेकर हम करेंगे क्या? सिर्फ रिसर्च, या तो नई दवाई बनानी है या तो हमको नॉलेज लेना है, तो वही होगा। तो प्रैक्टिकल नॉलेज में कैसे इसको कन्वर्ट किया जाए? तो प्रैक्टिकल नॉलेज कैसे दिया जाए? क्योंकि पेशेंट काउंसलिंग करेंगे तो ही ये सब नॉलेज उपयोग में आने वाला है। तो 75 साल में हमने कभी पेशेंट काउंसलिंग किया ही नहीं है। तो जो क्लिनिकल फार्मासिस्ट की प्रैक्टिस है, जैसे अदर कंट्री में है, वैसे इंडिया के फार्मासिस्ट कर ही नहीं रहे हैं। तो वो प्रैक्टिस हमको इंडिया में एस्टेब्लिश करना है। ऑलरेडी फार्मेसी प्रैक्टिस रेगुलेशन 2015 में गैजेट हो गया, अभी तक हमने इम्प्लीमेंट नहीं करवाया। मतलब प्रैक्टिसिंग प्रोफेशन में इम्प्लीमेंट नहीं करवाया। तो उसको हमको करवाना पड़ेगा, क्योंकि आपके पास पावर्स है पर आप अपना पावर्स का यूटिलाइजेशन करते नहीं हो। जैसे डॉक्टर्स अपनी प्रैक्टिस करता है, वो नेशनल मेडिकल काउंसिल या तो स्टेट मेडिकल काउंसिल में रजिस्ट्रेशन करवाता है और वो अपनी प्रैक्टिस करता है। वैसे लॉयर अपनी बार काउंसिल में रजिस्ट्रेशन करवाता है, बाद में वो प्रैक्टिस कोर्ट में कर सकता है। वैसे चार्टर्ड अकाउंटेंट का भी ऐसा है कि वो अपनी काउंसिल में रजिस्ट्रेशन करवाएगा तभी वो प्रैक्टिस कर पाएगा। और ये सारे लोग अपनी काउंसिल में रजिस्ट्रेशन होने के बाद प्रैक्टिसिंग करने के कंसल्टिंग चार्ज या तो प्रोफेशनल फीस चार्ज करते हैं। लेकिन हमारे फार्मेसी स्टेट फार्मेसी काउंसिल में रजिस्ट्रेशन करवाने के बाद वो अपना जो सर्टिफिकेट है वो कहीं पे रेंट पे दे देते हैं, या तो कहीं ना कहीं मतलब वैसे यूटिलाइज करके बैठ जाते हैं। तो ये जो पावर्स है आपके पास, रजिस्ट्रेशन जो स्टेट काउंसिल आपको देती है और आपको प्रैक्टिसिंग के जो पावर रजिस्ट्रेशन होने के बाद मिलते हैं, वो आपने कभी यूटिलाइजेशन नहीं किया है, तो कभी कभी आपने सोचा ही नहीं। तो क्लिनिकल फार्मासिस्ट की प्रैक्टिस मतलब पेशेंट काउंसलिंग करके आप कैसे, मतलब हेल्थ कॉन्शियस पीपल है बहुत सारे आज के देश, मतलब हमारे देश में बहुत सारे हेल्थ कॉन्शियस पीपल है, जहाँ उनको अच्छी एडवाइस और अच्छी मेडिसिन, मतलब कैसे मेडिसिन लेना चाहिए, डोज ऑफ एडमिनिस्ट्रेशन क्या है, कितने ग्राम लेनी चाहिए, कौन सा फूड इंटरेक्शन, कौन सा ड्रग इंटरेक्शन होगा, मतलब पूरी नॉलेज हमारे पास है। लेकिन कभी हमारा नॉलेज हमने अप्लाई किया नहीं, और वो नॉलेज का हमने कभी पैसा चार्ज भी नहीं किया। इसीलिए हम ट्रेडिंग प्रोफेशन में घुस गए। और अभी आपको पता है कि मैन्युफैक्चरिंग से लेकर रिटेल शॉप तक, फार्मासिस्ट शॉप तक, हम सिर्फ दवाई का डिस्पेंस करते हैं, प्रैक्टिस नहीं करते। हम दवाई डिस्पेंस का काम करते हैं, वो भी दवाई का डिस्पेंस सिर्फ प्रिस्क्रिप्शन जो लिखा है उसमें इफ एंड बट कोई क्वेश्चन मार्क नहीं, और सीधा जो दवाई मतलब लेकर आएंगे हमने दे दिया, मतलब प्रिस्क्रिप्शन दिया, पैसा काटा और दवाई दे दी। लेकिन जो हमारा नॉलेज है, मतलब ये दवाई कैसे लेनी चाहिए, क्यों लेनी चाहिए, अगर कोई ओवरडोज लिखी है तो डॉक्टर से बात करके उनकी कंसल्टिंग करवाना। तो अगर ये हमने हमारा नॉलेज का यूटिलाइजेशन शुरू किया, तो आज की दिन में जो हमारा आज का सेमिनार है, सब क्लिनिकल पे हम काम कर रहे हैं, फार्माको विजिलेंस पे काम कर रहे हैं, एंटी माइक्रोबियल रेजिस्टेंस इतना हो रहा है उस पे भी काम कर रहे हैं, उसमें हमारा रोल बेहतर है। तो अगर हम ये सब प्रैक्टिसिंग शुरू करेंगे तो हमारे पास नॉलेज भी आ जाएगा, और उसका हम चार्ज भी घर बैठे ले सकते हैं। चाहे आप टीचर हो, चाहे एमफार्म के स्टूडेंट हो, चाहे आप पास आउट फार्मासिस्ट हो, घर बैठे आप 10-15 पेशेंट को पेशेंट काउंसलिंग करके अपना चार्ज ले ही सकते हैं। किसी ने मना ही नहीं किया, और कोई कायदे कानून में मना करने का राइट्स भी नहीं है, क्योंकि वो आपका नॉलेज है और आप चार्ज कर सकते हो। तो मेरा आज का विषय यही है कि आज की जो कॉन्फ्रेंस है, हम क्लिनिकल और हार्ट डिजीज पे हम जो चर्चा कर रहे हैं, अगर आपके पास ये नॉलेज आएगा तो आप पेशेंट काउंसलिंग करना शुरू करिए, और तभी आपको पब्लिक और गवर्नमेंट में हमारे फार्मासिस्ट की इमेज भी बढ़ेगी, और इमेज बढ़ने के साथ हमारा इम्पोर्टेंस और फार्मेसी प्रोफेशन का इमेज और डे बाय डे ग्रो अप होगा। दूसरा हमारा जो पावर्स है कि इंडियन फार्माकोपिया कमीशन है, आपको पता है कि हम सब पढ़ते हैं इंडियन फार्माकोपिया कमीशन, पर कभी हमने एंटी माइक्रोबियल मतलब जितनी भी साइड इफेक्ट्स जो दवाई में रिपोर्टिंग होती है, एज अ फार्मासिस्ट हमारी ड्यूटी है, चाहे हम मेडिकल शॉप में काम कर रहे हो, चाहे हम पब्लिक लाइफ में है, चाहे इंडस्ट्री में है, चाहे कहीं पे भी है, अगर कोई दवाई की साइड इफेक्ट्स आपकी नॉलेज में आ रही है, वो रिपोर्टिंग करना हमारा फार्मासिस्ट के पावर से, और हमको हमारी ड्यूटी है। तो कभी हमने इंडियन फार्माकोपिया कमीशन की जो मोबाइल ऐप है, जिसमें ये सब रिपोर्टिंग्स होता है कि आप दवाई का फोटो खींचो, कौन से साइड इफेक्ट्स है, कौन सा पेशेंट है, पूरी डिटेल लेकर आपको डेटा अपलोड करना है। अगर ये डेटा हमने अपलोड करना शुरू कर दिया तो आप समझिए भारत देश में हमारे पास कितने फार्मासिस्ट हैं, मतलब 20 लाख से ज्यादा हमारे पास फार्मासिस्ट हैं। जो दवाई हम 10 साल के बाद बैन करते हैं, मतलब 10 साल के बाद हमको पता चलता है कि इसकी साइड इफेक्ट्स ज्यादा थी, ये लीवर को डैमेज कर रही थी, किडनी को कर रही थी और हार्ट पे इफेक्ट आ रही थी। 10 साल के बाद वो इफेक्ट कम करने के लिए और नई दवा का संशोधन हो जाता है, और बाद में वो दवाई लेने के बाद उसका भी 10 साल के बाद उसको भी कम करने के लिए और दवाई का रिसर्च होता है। मतलब एक कंटिन्यूअस आप हिस्ट्री उठा के देखें तो ऐसा ही हो रहा है। अगर हमारे फार्मासिस्ट जैसे ही दवाई मार्केट में कोई लॉन्च होती है, अगर हम डे वन से साइड इफेक्ट रिपोर्टिंग करना शुरू कर दिया, तो कहीं ना कहीं आपके फैमिली मेंबर्स भी वो दवाई ले ही रहे होते हैं, आज नहीं तो कल वही दवाई आपके परिवार में कोई ना कोई तो ले ही रहा होता है। तो वो रिपोर्टिंग करना हमने शुरू कर दिया, तो भारत देश को हम एंटी माइक्रोबियल रेजिस्टेंस और जो साइड इफेक्ट्स इतनी ज्यादा हो रही है, और जो फार्मा कंपनियां अपने इंडिया को एक बहुत ही बड़ा बिजनेस का एक मॉडल देख रही है कि इंडिया की पॉपुलेशन में दवाई हम लॉन्च करेंगे तो इतने करोड़ की ब्रांड वैल्यू हो जाएगी, वो ब्रांड वैल्यू अब हमको डिसाइड करना है कि कितनी करवानी है। तो उसके लिए हमारा जो पावर्स है कि साइड इफेक्ट रिपोर्टिंग करना, वो हम करेंगे। तो एक ही साल में जो नया मॉलिक्यूल आएगा उसकी साइड इफेक्ट ज्यादा होगी तो वो बैन भी हो जाएगा, अदरवाइज उसका जो अपडेटेड वर्जन है रिसर्च में वो भी आ जाएगा। तो मेरा मेरा कहने का यही मतलब है कि कभी हमने फार्मेसी प्रोफेशन में प्रैक्टिसिंग का काम किया ही नहीं है, चाहे पेशेंट काउंसलिंग हो, चाहे मतलब जो साइड इफेक्ट्स है उसका रिपोर्टिंग का काम हो। लेकिन हम इतने सारे एजुकेशनलिस्ट मतलब रिसर्च लोग बैठे हैं, सारे टीचर्स हैं, स्टूडेंट्स हैं, हम इतने सारी कॉन्फ्रेंस करते हैं, उसका आउटकम भी हमारे पास आता है, लेकिन उसका सही मायने में उपयोग पब्लिक लाइफ में कैसे किया जाए वो अपने को सोचने के लिए और सेमिनार का आधा घंटा और 1 घंटा रखना चाहिए, और इस पे चर्चा होनी चाहिए कि पेशेंट काउंसलिंग की प्रैक्टिस इंडिया में कैसे एस्टेब्लिशमेंट हो। बस यही हमारा आज का एक मैसेज है आज की कॉन्फ्रेंस में। और आपके जो कॉन्फ्रेंस है वो बहुत ही सक्सेसफुल जाए, और आप भी जैसे बहुत सारे लोग इकट्ठा हुए हैं तो कहीं ना कहीं एक दूसरे का नॉलेज शेयरिंग होगा, और वो नॉलेज शेयरिंग पब्लिक लाइफ में पब्लिक को उपयोगी हो वैसा हम काम करेंगे। उसकी वजह फार्मेसी प्रोफेशन की भी वैल्यू बढ़ाएंगे। और फार्मेसी काउंसिल इंडिया ऑलरेडी फार्मेसी प्रोफेशन के लिए काम कर रही है, और आपका सजेशन होगा तो काउंसिल में भेज दीजिए, उसके लिए भी हम काम करेंगे। और आप सबने मुझे शॉर्ट समय में कॉन्फ्रेंस में बुलाया उसके लिए सभी लोगों का धन्यवाद। थैंक यू। जय हिंद, जय भारत।
Thank you, sir. It's our honor to hear from you. Ladies and gentlemen, this was Dr. Montu Kumar Patel, President, Pharmacy Council of India. Please give a huge round of applause. Now, it's my privilege to introduce our guest of honor, Dr. Deependra Singh, Chairman, Education Regulation Committee, Pharmacy Council of India, New Delhi.
Dr. Deependra Singh is currently employed in one of the biggest and oldest universities in the state, Pandit Ravi Shankar Shukla University, Raipur, Chhattisgarh. He is the Pharmacy Council of India's nominee and has been heading Education Regulation Committee since his appointment. He has been conducting research and teaching for around 19 years. The development of various bioactive delivery systems for wound care, the creation of strategies for the delivery of proteins and peptides, sophisticated statistical and mathematical modeling techniques, tissue culture techniques, and the creation of innovative systems for the delivery of plant extracts and actives are among his primary research areas. More than 110 research review articles with an age index of 30 and an I-10 index of 90 with citations of more than 4,723 have been published by him in national and international publications. He has been granted 2 Indian and 2 international patents. He has finished multiple projects that were supported by DST, AICTE, ICMR, and UGC. In addition, he has received awards from the University Grants Commission, New Delhi, UGC Research Award in 2012 and 2014. The Department of Health Research ICMR Young Indian Biomedical Scientist Award 2019 and the UGC Raman International Award 2014. According to the Stanford University poll conducted in the years 2021, 2022, and 2023, Sir was among the top 2% of the scientists globally working in the fields of pharmacy and pharmacology. Sir recently received the esteemed Professor C.J. Shishu Award for Research and Pharmaceutical Sciences from the APTI Dr. LVG Nardgund of Nardgund Research Foundation.
This honor recognizes his outstanding teaching skills, research achievements, and commitment to influence the future of pharmacy education. Additionally, he has received numerous major state-level prizes for distinction in research. In 2006, the state of Chhattisgarh awarded him Young Scientist Award in Medical Sciences. He mentors and assesses states for the National Children's Science Congress. In addition to holding the position for Vice President for the Central Zone APTI and IPGA, he is a life member of numerous professional associations, including the Indian Pharmaceutical Association, the Association of Pharmacy Teachers of India, and the Indian Society of Pharmacognosy, the National Center for Natural Products Research, School of Pharmacy, University of Mississippi, USA, School of Medical Sciences, Deakin University, Australia, AIMST University, Malaysia, and the University Sultan Zainal Abidin, Kuala Terengganu, Malaysia, are just a few of the nations he has traveled to for scientific and research collaborations.
We would like to invite Dr. Dipendra Singh for his valuable speech. Sir, please.
Thank you so much. A very warm good morning to all of you. Sometime when somebody is reading your achievements, so again you revisit it, okay, I have done it. So thank you so much. A very relevant topic. I'm starting from President from where he has started. That why this heart is always very important from the point of view of physicians and from the point of view of poets also. It is always a very important topic and we all are aware. So I'm not going to talk much about the heart, but definitely I'm going to talk about the purpose that why we are doing this seminar on this topic. So most respectful Pro-Chancellor, Lieutenant General V.K. Sharma ji, Honorable Vice Chancellor officiating, Dr. Anil Vasist ji, keynote speaker of today's seminar, learned physicians from Gajra Raja Medical College and AIMS, Bhopal, Dr. Puneet Rastogi ji and Dr. Ratinder Jha ji, Director of this institute, Dr. Mohana Lakshmi ma'am, and one of the most important reason that I am here, Dr. Naveen Sharma, who continuously followed me and forced me to come here, I can say, he forced me to come here. But I'm telling you, this is always my interest, my just desire to interact with people because I'm just studied in Madhya Pradesh and I'm always feel connected. My whole study is from this state and I always feel connected to my fellow colleagues. Off the dais sitting, my buddies, my senior, Mishra sir is sitting, Dr. Jadon, Dr. Agarwal, Dr. Bharadwaj, and a lot of other people to whom I know personally, because when I was coming, Mohana madam saying, okay, you have interacted. So definitely I'm having very thick connection with all the people who are associated with the profession. So thank you so much for inviting me in this function. And most important, my dear students, because what I feel, conferences like this gives you opportunity to interact and enhance and improve your knowledge. But at the same time, this is also an opportunity to make relationship with each other. So utilize this opportunity. I'm starting with the topic that why this topic is very important. Friends, right now I'm having a responsibility of designing your new curriculum. And since last 7 to 8 months, we are very rigorously working on the curriculum. And when we talk about designing a curriculum in 2024, then how it can be relevant for the next 5-6 years or at least 8 years. So what will be the new things, or what will be the new techniques, and what will be the practice where we will focus? Because if you'll see, the events like COVID has changed the your thought processing, or the purview, or you can say that what the expectation you are having. Overnight the thought is changed. What we were having, again it was rethought. We are talking about now, the overall emphasis is talking about practicing of pharmacy. Initially we'll see that our whole course or approach was towards the industrialization or towards the industry, and definitely we have done very good in that, and that's why we are called the pharmacy of the world. So we are the largest manufacturers of the medicine and vaccines. So that was the achievement due to the syllabus or the design what we have provided to the student. But right now, after COVID, when COVID was there, it was thought that we are an integral part of healthcare system. And when doctors and nurses at that time, they were busy in the hospitals. So we were the people among the society who were directly helping them, and without PPE kit. So that was the reason that government has also underlined the healthcare, a very big force of healthcare system or part that can be utilized for the betterment of the public. So again, we called by the ministry, and it was discussed, and they asked from the council that how your pharmacist can help the people and can reduce the burden of the doctors who are working in the hospital day and night. So at that time, it was decided, or it is, again I'm saying, government is going to give guideline for the appointment of clinical pharmacists in every hospital. Because if you'll see to the doctors, there is a lot of burden to them, but at the same time they cannot take all the histories and everything from the patient, their food habits, their interactions, previous history of interaction, family history of that. So in that case, they suggested that people like clinical pharmacists can help in so many ways, specifically in the reporting of ADS, adverse drug reactions. So this is one of the reason that why we are working. And I'm telling you, the new syllabus what we are going to have in the coming session, that will be a very specific and specialized, having a very different syllabus. And in that, apart from this, the regular the present syllabus we are having, we are going to start specialization from the 3rd year. And people who wish to work in a different area, they will have a choice to opt that particular area. Right now we are having no option for the student that if they want to go to industry, they can have a specific knowledge. If they want to practice in the society, they can have a specific knowledge. Or like that, in the hospital or clinical side, they want to work, they want to go for the administration services. Because our profession is very dynamic profession, and we are having n number of scope in the society. So accordingly, we are trying to give you options. Because if you'll see NEP 2020, again, it is talking, the center is student, and they are talking about the liberty and choice for them. So this is again, we from the government and from the ministry, we are having instruction that we have to start, or pharmacy should also opt NEP 2020, and they should implement in their syllabus. Though we are a profession who are related with the healthcare system. So, but again, they said, okay, you start and you can, because we are having a large base of students. So again, that will be a very ambitious project for them, that we can implement NEP 2020. In the last few years, or if you'll see, the number of institutions has almost tripled. When I was studying in Madhya Pradesh, there were only 4 pharmacy colleges. And there was a lot of competition to get admission in the pharmacy. But right now, if you'll see, overall total number of colleges in India, it is more than 7,000. At that time, it was less than 1,400 colleges all over India. And now this is 7,000. So again, at the same time, you are having opportunity to get this course. But again, quality is concerned. So when President was saying why we are implementing so many specific AI based tools to implement or to inspect the institution. That is the reason, because right now this is not an issue that we are not recognized, we are recognized. जब मैं हमेशा कहता हूँ स्टेज से कि जब हम पढ़ रहे थे और मैं बहुत काफी दूर से यहाँ मध्य प्रदेश ट्रेवल करता था पढ़ने के लिए, मुझे 24 घंटे से ज्यादा लगता था अपने कॉलेज पहुंचने में अपने घर से, और रास्ते में बहुत बार लोगों से इंटरेक्शन होता था तो पूछते थे कि बेटा क्या कर रहे हो, और जब भी उनसे बोलो कि हम बी फॉर्म कर रहे हैं तो उनका आंसर ये होता था कि बेटा अगर आप बी कॉम ही करना था तो आसपास से कर लेते, इतने दूर क्यों गए थे। सो मेरा कहने का पर्पस है कि एट दैट टाइम पीपल वे आर नॉट वेरी क्लियर अबाउट कि यू आर डूइंग बी कॉम और बी फॉर्म. It was so, I am talking about my time. But right now there is no issue of the pharmacists are not recognized. But again, at the same time, if you want to get respect, because we get, if you want to respect, then you have to work on the knowledge. President was saying you are not in the practicing pharmacy because to become a practicing pharmacist, again, you require a knowledge. I never criticize any syllabus because syllabus are always very good and very relevant, crafted at that time. But how you are taking it, how you are using it, how you are acquiring knowledge out of that, that is very important. So the biggest issue is what the presently you are having to acquire knowledge or to get knowledge from that course or practical. आप कभी भी अच्छे समय का इंतजार नहीं कर सकते हैं. बहुत बार बहुत सारे लोग अच्छे समय का इंतजार करते हैं कि ये अच्छा समय आएगा और कुछ ऐसा होने वाला जिसमें हमारे साथ बहुत अच्छा हो जाएगा. ऐसा बिल्कुल नहीं होता है. सबसे अच्छा समय यही समय है. सबसे अच्छा इंस्टीट्यूशन जिसमें आप पढ़ रहे हैं, सबसे अच्छे शिक्षक जो आपको पढ़ा रहे हैं, ये अगर ये बात, सबसे अच्छे बुक्स, सबसे अच्छा सिलेबस जो आप एक्वायर कर रहे हैं, अगर आपके साथ ये फीलिंग है, अगर आपके साथ ये विचार है, तो डेफिनेटली यू आर गोइंग टू डू वेरी गुड इन योर फील्ड. जो भी अवेलेबल रिसोर्सेज हैं, जो भी अवेलेबल इंफॉर्मेशन हैं, उसको हाउ यू कैन यूटिलाइज बेटर, बिकॉज यूजिंग द सेम सिस्टम, people are sitting on the dais, people are speaking in front of you, so you cannot criticize that it was not up to the mark. मैं हमेशा एक स्टोरी शायद पहले भी कुछ सुने होंगे तो मैंने कहा होगा कि जैसे हमारे फार्मेसी के लोग बहुत क्लोजली एसोसिएटेड रहते हैं मेडिकल से, क्योंकि मोस्ट ऑफ द टाइम वो मेडिकल का एंट्रेंस देते हैं और क्वालिफाई नहीं करते, तो उनका सेकंड चॉइस फार्मेसी रहता है. बहुत सारे ऐसे लोग होंगे जो हॉल में बैठे होंगे जिनने मेडिकल की तैयारी की होगी, नीट दिया होगा, सेलेक्ट नहीं हुए होंगे, देन दे ऑप्टेड द अदर, हाउ वी कैन गो इनटू द हेल्थ केयर सिस्टम, सो दे ऑप्टेड फार्मेसी. आई एम आल्सो अमंग देम. ओके, सो इट इज ऑलवेज ऑलवेज ए इंटरेस्ट दैट इफ एनीबॉडी हैज क्वालिफाइड दैट यू वांट टू इंटरेक्ट विथ हिम. बहुत समय बाद मैं ट्रैवल कर रहा था और मेरे साथ एक बच्चा ट्रैवल कर रहा था, तो मैंने उससे पूछा कि तुम्हारा चेहरा बहुत देखा हुआ लगता है. तो उसने मुझे बोला कि हाँ, मैंने इस बार एमपी का जो पीएमटी है वो टॉप किया है. तो मैंने बोला हाँ. बोले मेरे पेपर में फोटो छपे थे इसलिए आपको मैं देखा हुआ लगता हूँ. तो मेरा ऑब्वियस से क्यूरियोसिटी था कि मैं उससे बात करूँ कि तुमने टॉप किया तो ऐसा क्या किया था, क्योंकि मैंने ही पढ़ा था. तो मैंने उससे पूछा कि अच्छा तुमने कैसे पढ़ाई करी, मतलब क्या किया था तुम टॉप किए, तुम्हारा पढ़ाई का पैटर्न क्या था. उसने बहुत सिंपली, उसका आंसर इतना सिंपल था, और इसलिए स्टोरी में बता रहा हूँ कि हम बहुत अच्छे की खोज में हमेशा परेशान रहते हैं और जो आपके पास रहता है उसको हम कभी यूज नहीं करते हैं. उसने मुझे एक बहुत अच्छी सी बात शेयर करी. मध्य प्रदेश में सब जानते होंगे कि युगबोध प्रकाशन हुआ करता है, अभी भी है, आई थिंक सो कि है युगबोध प्रकाशन. तो उसने बोला कि मेरे पास 3 बुक्स युगबोध प्रकाशन की थी, फिजिक्स, केमिस्ट्री और बायोलॉजी. लेकिन इसके अलावा मैंने ज्यादा किताब रेफर नहीं करी, लेकिन मेरे तीनों किताब मुझे बहुत अच्छे से आते हैं, बहुत अच्छे से. मैंने बहुत सारी खोज नहीं करी. जो पीएमटी की तैयारी की होंगे उसमें बहुत सारे मल्टीपल बुक्स मिलते हैं आपको कि आप इससे ये पढ़ो, इससे ये पढ़ो, इससे ये पढ़ो, बहुत सारे आपको चॉइसेस देते हैं कि आप ये पढ़ के शायद आप अच्छा कर लोगे. तो उसकी स्टोरी मैं आपको क्यों सुना रहा हूँ, जो उसके पास अवेलेबल रिसोर्सेज थे उसको उसने कैपिटलाइज किया और उसने टॉप किया. तो हमेशा कभी हम बहुत अच्छे नोट्स, बहुत अच्छे बुक्स, अच्छे टीचर, अच्छे इंस्टीट्यूशन की खोज में ज्यादा ना लग के, जो आपके पास अवेलेबल रिसोर्सेज है, जो अवेलेबल आपके पास टीचर्स हैं, जो अवेलेबल आपके पास इंस्टीट्यूशन है, उसको सबसे बेस्ट यूटिलाइज करें. डेफिनेटली आप अपनी लाइफ में बहुत अच्छा करेंगे. जो, और ये कहने का मेरा पर्पस, मैं फिर से अपने पॉइंट को वापस ले जा रहा हूं. इफ यू वांट टू बिकम ए प्रैक्टिसिंग फार्मासिस्ट, देन नॉलेज इज वेरी मच रिक्वायर्ड. इन दिस एरा वी आर नॉट लैकिंग नॉलेज. नॉलेज इज फ्लोइंग फ्रॉम एवरीवेयर. जो लोग स्टेज पे बैठे होंगे, मैं उनको अगर उनके टाइम का रिसर्च या उनके टाइम की पढ़ाई को अगर रिकॉल करूं, तो उस समय अगर उनके टीचर या गाइड अगर उनको किसी पेपर को रिफर करने के लिए या किसी केस को स्टडी करने के लिए अगर उनको कहते होंगे, तो उस बात में कम से कम महीनों लगते थे. अगर उनके लाइब्रेरी में अगर वो रिसोर्सेज अवेलेबल नहीं है, उनका रिक्वेस्ट जाएगा, कहीं से फोटोकॉपी होगी, फोटोकॉपी होकर पोस्ट से आएगा, फिर हमको पढ़ने को मिलेगा। तो गेटिंग अ नॉलेज वाज अ वेरी डिफिकल्ट एट दैट टाइम, बट आज आपको नॉलेज एक्वायर करना बहुत ईजी है। हाउ मेनी पीपल यू आर यूजिंग चैट जीपीटी? कितने लोग हैं? लॉट ऑफ पीपल। एंड यू नो व्हाट चैट जीपीटी कैन डू। आप एक अपना क्वेश्चन उसके सामने रखिए और जिस भाषा में चाहिए आपका रिलेवेंट आंसर आपके सामने रखता है। So not knowing about a topic and knowing about a topic, there is only a difference of few seconds. Just you have to put your question in front of him, in front of that app, and it will give you answer. So now the knowledge is not issue. How you are going to utilize that knowledge, that is a issue. So if you want to become a practitioner, and that is why people are saying, because there is always a limitations of any industry. Industry is having certain limitation, that certain capacity that they are going to absorb you. Then, but as I said, the number is again, institution is very high. The output of the people who are coming from the institution is again very high. Then we are also requiring new areas in which we can utilize our knowledge. And basically we are associated with the healthcare system. So what the knowledge you are getting, what the information, what the time you are spending on getting this knowledge, it should be properly utilized. हम किसी भी समय जो हम, अगर आप देखेंगे एक प्रिंसिपल हमेशा सब जानते हैं, एनर्जी इज नेवर क्रिएटेड नॉट डिस्ट्रॉयड, इट इज ऑलवेज चेंज, और द फॉर्म इज चेंज। तो जो आप एनर्जी इतना वेस्ट करते हैं इस इंफॉर्मेशन को लेने में, अपना समय लगाते हैं, टाइम लगाते हैं, अगर आपने इसको प्रॉपर यूटिलाइज नहीं किया तो वो हम एक अपने बहुत बड़े जो रिसोर्सेज का वेस्टेज बोलेंगे। So practicing pharmacy is again a very good scope for the our pharmacist. Clinical side में काम करना, because if you will go to the countries to whom so called the advanced countries, there the role of the pharmacist is very different. They never use as a dispenser of the medicine. They are always expert of the medicine. They work on that. And why they work on that? Because they are having a vast knowledge of their medicine. The issue is, maybe you are asking for that I should get respect. If you want to get respect, because respect is never demanded, it is always commanded, and you can command only by getting the information, knowledge of your subject. हम में से कितने लोग capable होते हैं कि we are having a prescription and you are having a guts to challenge to a physician that no, this is not there, or this is having interaction, or you have written 3 medicine and it is having interaction with each other, or it should not be prescribed with that, because you never work on that. And we always think, okay fine, बहुत अच्छे जो फार्माकोलॉजिस्ट हैं वो भी नहीं पूछते होंगे फिजिशियन से कि अगर उनको दिमाग में भी आता हो तो ये हम कैसे कर रहे हैं, बिकॉज वी ऑलवेज से इट इज फाइन। तो अगर किसी चीज में प्रैक्टिस करना है तो आपके नॉलेज को बहुत इनहांस करना पड़ेगा, बहुत आपको केपेबल होना पड़ेगा, तभी आप जाके इस फील्ड में प्रैक्टिस को, जैसा वो कह रहे थे कि लॉयर प्रैक्टिस करते हैं, ठीक है, प्रैक्टिस बाकी डॉक्टर्स प्रैक्टिस करते हैं, तो आप सोचिए कि डॉक्टर्स क्यों प्रैक्टिस करते हैं। वाई वी फेथ ऑन अ डॉक्टर? बिकॉज दे नो कि दे हैव टू बी वेरी सीरियस अबाउट देयर प्रोफेशन, बिकॉज अगर वो गलती करेंगे तो एक जान जाएगी। तो वो इसीलिए सीरियस है अपने पढ़ाई के लिए, वो इसीलिए अपने नॉलेज के लिए सीरियस है, बिकॉज दे आर डीलिंग विद द हेल्थ ऑफ पीपल। यू पीपल आर आल्सो डीलिंग विद द हेल्थ ऑफ द पीपल, बट वी नेवर कंसीडर आवरसेल्फ दैट वी आर सो important in the healthcare system. Once you will find your importance, then definitely you will work on your knowledge. क्योंकि अगर आप भी अगर गलती करेंगे और किसी के साथ एक अगर उसके जान पे बनेगी, तो आप डेफिनेटली उस बात को केयर करेंगे और कोशिश करेंगे कि हम इसको बहुत अच्छे से करें। The topic what we have taken, again, I am very happy that there is a workshop on CPR, and definitely I'll urge upon you that that is very much required, because practicing is very important, because I have seen that people know about the CPR, I know about the CPR, but when you face a such situation, then we are not in position to just execute it. So doing such type of workshops, practicing of that workshops make you eligible to do that, and also you will have a experience of doing that. So again, I'm urging upon you that take your course very seriously, take your syllabus very seriously, always have a habit. We are having a topic that we are talking about prevention, management and treatment. So prevention, we can talk about the prevention, management and treatment will be with the physician, but we can talk about the prevention of that disease. So एक बहुत सिंपल सा मंत्र है कि एटलीस्ट 40 मिनट्स हम फिजिकल अपने को समय दें, फिजिकल एक्सरसाइज, वॉक, किसी भी चीज पे 40 मिनट्स इज ऑलवेज recommended, requested. सो वो करें। और दूसरा मेरा रिक्वेस्ट है कि हर दिन कुछ पढ़ के सोएं। जब सोने का मन हो फोन किनारे रखें, एटलीस्ट 1 घंटे पहले जो भी पढ़ना हो पढ़ के सोएं, और जब सुबह उठेंगे तो आप कुछ बढ़ के उठेंगे। सो थैंक यू फॉर इनवाइटिंग मी इन दिस फंक्शन। जय हिंद, जय भारत।
Thank you, sir. It was wonderful hearing from you and learning from your experiences.
Taking the session forward, we'd like to request Honorable Pro-Chancellor to kindly felicitate our guest of honor, Dr. Dipendra Singh. Sir, please. Before getting into the session, let me give you brief insights on cardiovascular health. Cardiovascular health is a cornerstone of overall well-being, encompassing the proper functioning of the heart and blood vessels, along with playing a pivotal role in maintaining vitality, longevity, and quality of life. It is also fundamental to overall well-being and societal prosperity. With this note, I would like to invite Dr. Puneet Rastogi, Professor and Head, Department of Cardiology, Gajra Raja Medical College and JA Group of Hospital, Gwalior, to share a few words with us. Sir, please.
First of all, I will apologize for getting late because I was stuck up with one of the VIP patients. I mean, on the lecture. Respected V.K. Sharma ji, Deepen ji, Director Mona Lakshmi ji, Vice Chancellor ji, and my colleague Dr. Ratna ji from AIMS. आप लोग अभी लेक्चर्स सुन रहे थे दीपेन सिंह जी से। उन्होंने एक बहुत बढ़िया बात कही, वो जिसने टॉप किया था। This is absolutely correct. When I was a CBSE topper in 12th, I only read the books which were prescribed by CBSE. And when I passed out at that time, 90% was my aggregate marks, which was very rare to get at that time. So one thing you should always remember, if you go medical wise, how do we develop memory of a system? Suppose I read a book, the synapses, the memory goes to the synapse, it goes to the brain. Again, if I read the same book, it will further confirm. When I read it third times, the memory synapses get accustomed to it. So all of you know there are memory cells in it. So if you keep on reading from the same book, your receptive power increases and simultaneously your reproducibility increases furthermore. So this is very, very important. So whenever you are preparing for your exam, you have to read only one book. Now, if you have to add on, take the papers from the other book, add on to that book. So that when you read it, you have a memory of that book. If you go in exam, remember that from the back of the memory, it will come, okay, I've read this. So that is very, very important. And always remember this, the same class, same teacher is teaching 100 students, but only one of them is successful. It is not the defect in the teacher, it is defect in us. So whenever you are trying to approach something, remember one thing, very, very important. Never compete with anybody. You are your own competitor. Find faults in yourself, not find faults in others. The more deeper roots you have, the more better you will grow. Don't try to be superfluous. If you remember, the deep sea moves with silent majesty and the rivers are noisy. So the more knowledge you have, keep mum. And always remember the crux of life is until unless you give respect to the other people, you cannot get it. As already told, very good line. The respect is never demanded, it is commanded. If you are good, everybody will respect you. People around you will really feel nice. Today, the lecture topic which has been given, it is really very good because we will be discussing various aspects based on you. What are the newer drugs? What problems we are facing? Is treatment required for every disease and form of operation? Can we prevent them? Because at present, India is #1 country in all over the world to have maximum coronary artery disease patients. And we do not want that to spread. We want that we should cut off this. What you people know is only the tip of the iceberg, very small amount of the disease. After COVID, we are operating almost 20 patients per day of coronary artery disease. This is the manifold increase in Gwalior. So you can understand how much amount of coronary artery disease is increasing. I hope this seminar and this conference will really abreast you with the latest technology and help you in your future perspectives. Always the last word I'll say, you are the only, you have to fight yourself. There is no other competitor. If you fight with yourself, try to find your faults, you will grow mammothly. Thank you very much.
Thank you, sir. We would now like to request Honorable Pro-Chancellor to kindly felicitate Dr. Puneet Rastogi. Thank you, sir. Thank you, ma'am.
Now, I would like to invite our second keynote speaker on the first day, Dr. Ratinder Chaj. working as Professor, Department of Pharmacology, All India Institute of Medical Sciences, Bhopal, to share a few words. Ma'am, please.
Thank you. A very warm afternoon. हो गया अभी तो. Good afternoon to all of you. And yeah, so first of all, I would like to begin by thanking our Pro Chancellor, Lieutenant General V.K. Sharma, for inviting me to this for this conference. Our officiating Vice Chancellor, Dr. Anil Vashisht, Madam Mohan Lakshmi, Director of MIT Institute of Pharmacy, and as Dr. Dipinder Singh has already said, my fellow keynote speaker has already said, the real reason but I'm here is due to the persistence and not hearing a no from Dr. Naveen Sharma. He's the one who, is, as he said, the reason for my being here. And I would also like, to thank and welcome my other keynote, fellow keynote speaker, Dr. Puneet Rastogi. Now, so I'll be addressing you again after, I think just before or after lunch. So I don't want to take much time right now. But a lot of what Dr. Dipender Singh sir and Dr. Montu Patil actually resonated with me. So just expanding on their themes. So I could, really relate to what Dr. Dipender Singh said about making the best resources, best of the resources that you have at your hand, by which I do not imply that you're not already doing it. I'm sure you're already making best use of your resources. But, like even when I was preparing for my post-graduation, I was working in a mission hospital. I had very few, I didn't even have all the textbooks. I had very few resources. And anyway, let's not make it about me. Our head of department at PGI, he was Dr. VK Bhargav. Still we remember him very fondly. So there was a co-resident of mine, of course I won't name him. So once he would always be complaining कि ये नहीं है डिपार्टमेंट में, ये चल नहीं रहा, अभी HPLC खराब हो गया, बुक्स हमारी पुरानी है डिपार्टमेंट लाइब्रेरी में. So once he approached our HOD कि सर बुक्स और चाहिए, with a big list of books. So what the HOD asked him कि पिछले internal assessment में आपको कितने marks मिले थे? And unfortunately it wasn't too good. So he said, बेटा ऐसे करो, पहले जो books हैं library में वो पढ़ लो, and then you come to me asking for more books. So again the gist was make the best of what you have rather than complaining, but at the same time aspiring for something more is obviously also not wrong, unless we speak up for what we feel is lacking in any way in our teaching, in our and learning environment, then obviously there will not be any improvements. So, okay, more than that, I think I'll leave it for my actual talk, seeing that we are running, I think, half an hour at least late. So hoping to, talk to you and interact. In fact, I'll make that a little, hopefully, more interactive. So I'll talk to you again. And thank you again to the organizers for having me here today in this beautiful city. Thank you.
Thank you, ma'am. As a special acknowledgement to you for managing your precious time to join us and making us feel honored by your arrival, we would like to request our officiating Vice Chancellor to kindly felicitate Dr. Ritinder Jaj. Sir, please. Thank you, sir. Thank you, ma'am.
Now, I'd like to invite the Director, Amity Institute of Pharmacy, to felicitate our Honorable Pro-Chancellor. Ma'am, please. I'd now request ma'am to kindly felicitate our officiating Vice Chancellor. Ma'am, please. Thank you, sir. Thank you, ma'am.
It is time now that we proceed towards the release of conference proceedings, which has been published out of the selected papers received for the conference.
We would like to request the dignitaries to kindly come forward and the members of scientific committee as well to join the dignitaries for the release of conference proceedings. I request the members of scientific committee to please join.
Amity Institute of Pharmacy is very felicitous to release the inaugural issue of Amity newsletter, AmiPharm. For this, I would like to request the members of editorial board along with the student coordinators to join the dignitaries and release the letter. Thank you, everyone. You may now return to your respective seats. Thank you, dignitaries.
Gratitude is the fairest blossom which springs from the soul. With this quote, I'd like to call upon the stage Dr. Naveen Sharma, Professor, Amity Institute of Pharmacy, to propose vote of thanks. Sir, please.
Ladies and gentlemen, a very good afternoon to all. On behalf of Amity Institute of Pharmacy, Amity University, Madhya Pradesh, it's my privilege and honor to extend a warm and heartfelt vote of thanks to all of you gathered over here on this auspicious occasion. First and foremost, I convey my deepest regards and hearty thanks to our Honorable Founder President Dr. Ashok K. Chauhan Sir of Amity University and Chancellor and Chairman Dr. Asim Chauhan Sir of Amity University, Madhya Pradesh, who always bless us with their motivational thoughts. It is with immense pleasure and gratitude that I stand before you today to extend a heartfelt vote of thanks to our esteemed Pro-Chancellor V.K. Sharma for his unwavering dedication and invaluable contribution in organizing this remarkable events. I would like to offer my deepest gratitude to Vice Chancellor, Pro-Vice Chancellor, Registrar, Dean and Directors for their constant guidance and support to the SAPE to the conference. I extend thanks to Chief Guest, Dr. Montu Patel, sir, who joined online. And I extend sincere thanks to our guest of honor, Dr. Deependra Singh, Chairman, Education Regulation Committee, Pharmacy Council of India, New Delhi, for gracing us with the esteemed presence and invaluable contribution to our gathering. Please join us a round of applause to express our deepest appreciation. Thank you, sir. My deep sense of gratitude and appreciation as we bring to a close this enlightened gathering, it is my privilege to extend a heartfelt vote of thanks to our esteemed keynote speaker, Dr. Puneet Rastogi, sir, Professor and Head, Department of Cardiology, Gajra Raja Medical College, Gwalior, Madhya Pradesh, Dr. Ratinder Jhaj, Professor and Head, Department of Pharmacology, All India Institute of Medical Science, Bhopal, Madhya Pradesh, for their invaluable presence in this conference, and they have exemplified excellence and leadership in their area of expertise, and their willingness to share their knowledge and experience with us as a testament to their commitment to advancing the frontier of knowledge and innovation. The presence of delegates from their as other esteemed institutions has not only add prestige to our event, but enrich our discussions with diverse perspectives and invaluable insights. Your participation reflects a shared commitment to academic excellence and collaboration. And it is a truly inspiring to witness the spirit of cooperation and solidarity among esteemed colleagues. No event takes shape without a hardworking leader. It is the dedication and enthusiasm of our convener and director, MIT Institute of Pharmacy, MIT University, Madhya Pradesh, Gwalior, Dr. S. Mona Lakshmi. Her determination is commendable, and it is her hard work which will make this conference a huge success. Once again, I would like to thanks to all. Thank you very much. Thank you.
Thank you, sir. We are extremely grateful that you all are the part of this virtuous conference. We hold the proceedings as of now for refreshment break of 15 minutes. All dignitaries are requested to proceed for high tea, which will be served in B Block VIP Lounge. And for the other delegates, arrangements are made in B Block foyer.
Everyone is hereby requested to be back in the auditorium after this quick refreshment. Thank you.
एक म्यूजिक डाल दो
अब मत करो
नवीन सर का
हेलो मोबिन सर।
हेलो।
मोबिन
हेलो,
सर आवाज आ रही है आपको?
हाँ आवाज आ रही है। आ रही है, आवाज आ रही है।
ठीक है सर।
इको हो रहा है, वही चेक कर लो एक बार।
हाँ हाँ। अब नहीं हो रहा होगा।
हाँ जी हाँ जी, अब नहीं हो रहा, ठीक है।
ठीक है सर। सर वो लीव यानी ऐसे ही रहने देते हैं, मैं साइड में रख देता हूँ। ठीक है तो
ओके ठीक।
क्योंकि ऑफलाइन ही है अब। ठीक है।
ठीक है ठीक है।
कोई कुछ नहीं है ना, वो बताइए कौन सा वाला है। हाँ वो करके रखना पड़ेगा। ठीक है। हेलो 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 चालू चाहिए कॉन्फ्रेंस भेज दियो मेरे को
हाँ मैडम यस यस
बजाओ नहीं बजाओ क्या अभी तो चेक हो जाएंगे। अब कौन सा म्यूजिक है? वो वाला मत बजा ना। ये वाली है ना, वो कह रहे मैंने मेल कर दी, ये वाली है ना उनकी पीपीटी ओपन कर दो ना जी। मैंने हाँ तो वो कह रहे हैं ना, बस चालू कर दो आप, बस वो कह तो रहे हैं। तभी तो मैंने आपको बस ठीक है, वो कह रहे हैं बस चालू कर दो, चालू कर दो।
Please to hand mic, hand mic, hand mic, hand mic.
Everyone is requested to please settle down quickly as we begin into our technical sessions. And please keep your phones on silent mode. Please settle down quickly. So,
Clear हो जाने से तब इसको लंच ये आगे कर देते हैं। Pro Chancellor sir is arriving. When he will arrive, then we will begin the session. Have to sit 11 to 11. Please maintain the distance.
everyone is requested to kindly settle down, please, and maintain the decorum of the auditorium.
Sir. Ma'am told me, like, so they didn't touch them. Sir, have an
Please be silent and maintain the decorum of auditorium. Please. Now we please welcome our Pro-Chancellor. Please stand up and give a big round of applause.
Everyone, please be seated.
Everyone, please be seated and put your phones on silent mode. A very good afternoon once again. Now that we are moving into our first technical session, for this, we are delighted to introduce our first keynote speaker, Dr. Puneet Rastogi.
Dr. Rastogi, Professor and Head of the Department of Cardiology, Gajra Raja Medical College and JA Group of Hospital, Gwalior, is a Fellow of European Society of Cardiology and Society for Cardiovascular Angiography and Interventions, and Associate Fellow of American College of Cardiology. Also, he is a Fellow of Indian Academy of Echocardiology and Indian Academy of Clinical Medicine. His work includes more than 50 international and national publications. His achievements and awards are Charak State IMA Award, Dr. M.C. Gupta Ocean in National Conference of India Academy of Clinical Medicine, Distinguished Faculty Award in Golden Jubilee Celebration of G.B. Pant Institute of Post-Graduation, Medical Education and Research, New Delhi. Gwalior Ratna Award for Outstanding Contribution in Medical Field, Best Medical Teacher Award by IMA Award by Government of Madhya Pradesh for Excellent Services in Cardiology. Sir has also performed more than 15,000 angiographies, angioplasty, and pacemakers.
Now we request Dr. Puneet Rastogi to kindly take over the stage. Sir, please.
It is audible, no problem. Thank you very much for kind words. Respected guest of honors, dignitaries, and my dear students. Today we'll be passing through one of the very important aspect. When the MIT University approached me for this lecture, I was very thankful to them because they have chosen a lecture which most of the people do not really want to. Because we are talking something not of management, but how to prevent it. See, we have more than 3 million people who suffer from heart attack or angina in India. And the age of presentation is dropping down. This is the figure of 2018. But if you look at the recent figure of 2022 last published, this has gone down to 50 years. And this is more than 60% of the total people. If you look worldwide, proportion of STEMI patients is more than 60%. So you can imagine that how much more percentage of people we are getting of coronary artery disease. Now, what do we need to treat all these patients? You want that we should treat them, or you want that we should diagnose first and prevent them? So today our issue is basically how to diagnose them early and how to prevent them. Can we go at the primordial prevention? Can we go at the primary prevention, or we should look only at the secondary prevention? It has become a leading cause of death in the world. But thanks to the technology that now we have gone into the molecular basis of diagnosis of cardiovascular disorders. And every year we are gaining in-depth information of what is the cause of cardiovascular disorders and what is the reason behind it, what is the genetics involved behind it. Therefore, we can have to first diagnose it and to treat it. Can we prevent it? Now, this slide becomes the crux of whole of the lecture, what we'll be talking about. As a students, when you were preparing for your exams at 10th class or 12th, you must have read there are basic risk factors in form of obesity, diabetes mellitus, hypertension, and raised cholesterol, which we call it dyslipidemia. But now we have more causes which we do not know, which are come to us. And how do they manifest? These are the causes which cause endothelial dysfunction. What is endothelium? Endothelium is the lining of the cell of the coronary arteries and arteries. Now they keep on secreting small amounts of hormones which prevent in situ thrombosis, like plasmin activator inhibitor, so that the thrombus does not form. They secrete NO, that is nitric oxide, to prevent the spasm of the coronary arteries. So if you have a healthy endothelium, you will not develop sudden onset cardiac arrest, you will not have spasm of the artery, you will not have thrombosis of the artery. Now, when you have risk factors, like you are born in a family whose parents have diabetes, they are hypertensive, they have genetically coronary artery disease. You cannot choose your parents, but you can choose your in-laws. Means when you're getting married, you should look into the genetics of the family and getting married. That becomes an important issue now. Whether the diabetes is running in the family, whether they have a coronary artery disease or they are hypertensive. Because if you combine two families who have a genetic coronary artery disease, the incidence will whoopingly rise of your children having a coronary artery disease. So where do we stand? When we are born, God does not gift us any fatty streaks or any cholesterol or any atherosclerotic plaque in our body. Now, what happens is when we start eating food which is rich in fat, we do not exercise, we sleep less, then what happens? The plaque formation start occurring. And this is how the plaque formation start occurring. So this is the initial stage of plaque formation. Now this will gradually keep on increasing. Initially, you will have foam cells, then you have atherosclerotic plaque, you have a calcium. Now these plaque can have a soft material and a hard material. If it is a soft material, it will rupture very fast and cause an acute heart attack. I'll give an example. You get an angiogram done, any of your relatives and doctor says there is blockage of around 20%. You are very happy. You go home and after 3 days, the patient is admitted with heart attack. Now, how it has happened? A 20% block will not cause the obstruction. But when the plaque ruptures, it causes in situ thrombosis because it will activate the platelet. The platelet will aggregate and will produce a platelet plaque, which will block the artery. So even a small amount of plaque which is present is deadly for you. So don't be upset that this plaque is 20% or 25% blockage. You have to look into the risk factors. You have to modify your lifestyle. So you have to start prevention right at the childhood. Now let us assume a condition. Even those patients who do not have a plaque or very minor plaque, 5% of them will develop a coronary artery disease, will rupture a plaque and will develop. 50% will have less than 50% stenosis, will develop. Those who have severe stenosis, they already know that they have got a plaque and that will rupture and will cause myocardial infarction. So our basic theme of today is that how to prevent the plaque formation and how to prevent the rupture of the plaque. So we go one by one. Now, what are the advances in cardiovascular research which has occurred, which will help us? Now, if you go, all of you who are here sitting, who are working, have know what is artificial intelligence. We have two groups. One is machine learning technique, another is a deep learning. Now, in machine learning, you have to feed the data. It incorporates the data and gives you the results. But in deep learning, it is a network of neural system. It can extract the data, pass it on the neural network, it redefines the neural network, then it goes into a convolutional neural network, and then gives a very modified data, which is very helpful in discussing about the preventive aspect of the disease. We can go back into what are the trials have been done. Are these trials looking into, you feed them into artificial data and you realize that it is important. Now, if I have to do an investigation, so I can make a decision support that which investigation is required. Once I do an investigation, I reconstruct the image, I do a post-processing of the image, and then I diagnose, okay, this is the disease. And I tell you that your prognosis is this. Your disease is bad or it is, what should be the prognosis? We are always bothered into diagnosing those diseases where we can go about, have the investigation done without any problems, no puncture of the arteries, no drug is to be given. So they have come out a very important investigation where they're assessing the epicardial fat, means the fat which is present over the heart, and also the pericoronary fat. If the quantity of the fat is more, you have a high risk of developing future myocardial infarction, future coronary event, that you may have angina, you may be admitted to the hospital. Now, with this artificial intelligence, we were using gadolinium MRI, where we give a dye into the vein, and then we used to localize this is the heart attack area. But with artificial intelligence, now we are able to see into that whether this area is viable or not. Now, if you have a heart attack, you have to see whether that tissue is living or not. If this tissue is living, you open up the artery, the patient will survive and do well. But if the artery is not, tissue is dead, even if you open up the artery, you are not going to achieve anything. Now, this is one of the most important which has come in last 6 months. We were getting CT angiography done of the patients, which is a very common investigation. Suppose at this age, I want to see my coronary arteries. I do not have my TMT is negative. My cholesterol levels are normal. Everything is normal. But still, I want to know my coronary arteries, whether they have a plaque or not. I go for CT angio. They will do my calcium scoring. If my calcium scoring is 0, it means my risk of plaque is very low. But then they do a CT angiography and see the coronaries. Now, whenever there is a small amount of calcium present, in persons, it is very difficult to localize whether the stenosis is severe or not. Now, they came out with a very specific, which is known as fractional flow reserve, which we do in the cath lab by putting a wire across the stenosis to see how much is the blockage. But here with artificial intelligence, you can see the blockage without catheterizing the patient. Now look at this. This was the patient who was diagnosed having a block of around 50% on CT. But when they did a FFR, they found that the block is more significant. And when conventional coronary angiography was done, they found it to be 70% block. So here the AI has helped in diagnosing. So basically, when you are going for a basic investigation, which is non-invasive, and you find that this patient has developed a blockage which was not significant with calcium. So this patient might develop a myocardial infarction later on. So this is what has happened. Now, this is another important. You have a patient, you are treating a patient, you did an angiogram in 2021. You find that he has a 40% block. Now, this patient comes to you, says, Dr. Sir, I am taking statins. All of you know what are statins because they are known to regress the plaque. Cholesterol level will come down. They are on antiplatelet drugs. Now, he said, Dr. Sir, I want to know. Now, this is the AI where you can see for the progression of the plaque. Sorry. Now, you look at the progression of the plaque. This was the plaque which was initially present. And now after 2 years, this plaque has increased. See, you can see the lumen here, but here the size of the lumen is decreased because the plaque has increased. So this is what AI has done to us, artificial intelligence. And this we got in last 6 months. One of the wonderful things where you can assess the morphology of the plaque, you can see whether the regression is occurring or not. Now we have an intravascular imaging. We are putting a stent directly initially. Now we can use intravascular imaging in form of intravascular ultrasound, or you can do in form of optical coherence tomography. Optical coherence tomography is much better. And these are some of the trials which will tell you October trial, Illumine trial, and Octavius trial, which have shown that both are comparable to each other. And they are very effective. You put in stent, you do a intravascular ultrasound, you can see the approximation of stents. And these patients, once you approximate well, they do not come back to you with restenosis. So it is basically preventing the restenosis also. Now, how it is effective in arrhythmias? We have most common arrhythmia, which is commonly seen as atrial fibrillation, where the heart rate is breaking continuously with increased rate. Now, what we want to do, we want to prevent this heart rate if we give drugs or we can do an ablation in them. So they have done a comparison trial with medical therapy and ablation therapy. They found it is equally effective. Now, when we want to anticoagulate them, what should be the anticoagulation? We should anticoagulate them immediately, which prevents the embolic stroke in them. Now, echocardiography, all of you are well versed. Most of you must have got yourself or your relatives done. Now, suppose you have a lesion of the heart. I have a valvular lesion of the heart, and you want to know whether it is progressing or not. So initially, the type of echocardiography we were getting was 2-dimensional. Then came the Doppler. Now we have a 3-dimensional echocardiography. Along with that, we have a AI, where you can see the movements of the valve. You can see the subvalvular apparatus of the valve. So this gives an idea whether this patient progression will be what. Whether you want to do a balloon valvoplasty in this patient, you want to implant the artificial valve, when he has to be sent for surgery, what will be the prognosis? So these things have really grown much faster because of AI. Now, the recent 2023 have seen a wonderful research into pharma. And if you look at this drug, Gelibreseran, which is a RNA interference therapeutic agent. Now, can you imagine you take only one drug once a month and it is effective throughout the month? So this is the drug. You are using 200 milligram, only injectable once a month, wonderful drug. Only problem what they are finding is the patient is having a local reaction at the site of the injection. So these are the some of the wonderful development. Now, all of you are aware of the latest drug GLP-1 receptor antagonist, which was basically used for treatment of diabetes. What they found out, it is a very good drug for weight reduction. Weight reduction, it is very good drug. Why? Because it causes satiety, it increases insulin secretion from the pancreas, and it regulates the glucagon according to your meals. So because of this, you are decreasing your obesity, you are decreasing the absorption of glucose, and because of that, the atherosclerosis is decreasing. Then they found out if you look into a healthy diet system, means you're eating less, you're sleeping well, you're exercising, over a period of years, you will find that your coronary artery disease will gradually regress. You will not even require drugs for it. You have a 20% blockage, it will gradually regress. Now, what technology has come is a nanomedicine cardiovascular disease technology. What are these nanoparticles? These nanoparticles are basically, if I have to deliver a drug at a particular place, or I have to deliver a drug inside the cell. Now, what I will do is, I'll take a nanomolecule, stents, I'll place a drug over the stent, implant the stent. Now, this nanotechnology drug will keep on regulating from the stent what we are doing in coronary arteries, in renal arteries, in cerebral arteries, so that with that small amount of drug, it will prevent the development of tissue growth, it will prevent the fibrosis, and it will prevent the platelet aggregation at that site. Other is, I want to deliver a drug inside the cell. So what I do, a nanomolecule, which has a ligand, which can go and attach to the receptors of the cell, where I want to give the drug. So it gets attached to the receptors port it, it directly goes inside the cell, delivers the drug, you get the best effect. So this is nanotechnology. Now, nanotechnology can be used in diagnostic also. Suppose I take the drug, I take the molecule in the RBC, and I give them IV, they will go to a particular site where you want to see for it, and you will see there is illuminance in that area. As we gadolinium, as we are doing SPECT, as we are doing SPECT MRI, these are all nanomolecule technology. So this is a great advancement in the field of cardiology, what we are doing. Now we come on to a system which is not well understood and people do not go into it. In fact, what is cardiac rehabilitation? Suppose a patient develops a myocardial infarction or develops an angina. You do an angiogram, you find his artery has opened up, the plaque is only 25%. But do you talk to him? Do you advise him how will you rehabilitate? How should he exercise? What food he should take? So this becomes a very important part of the rehabilitation. What we talk is only one thing. We talk of the drugs. Now, when we talk, we only understand one thing, and that is exercise. We come on to one by one what is cardiac rehabilitation. First, assess the patient. What is the patient like? What are the associated diseases of the patient? What is the BMI of the patient? And then you're prescribing a nutritional counseling. What types of food you should take? Then third comes weight reduction. Very, very important. 2 kgs per month is adequate. Don't push him too hard because he will develop then apoptosis, proptosis of all the organs. They will sag down in the abdomen. He's FT. Control your blood pressure. Now, what should be the level? When you are targeting a diabetic, its blood pressure should be less than 120/80. When you are targeting a renal failure, less than 130/80. When you are targeting a cardiovascular patient, 120/80. When you are targeting only hypertension, BP should remain always less than 135/85. So this should be a target. How will you manage lipid? This is very important. You should go into system. Now, a patient comes to you, cholesterol is 150, triglyceride is 150 normal value. LDL is less than 100, you do not have risk factor. You have not looked at the HDL of the patient. You say you are fine, you can very well go ahead. You don't need a drug. No. Look at the HDL. HDL is what? It is basically the system which is preventing atherosclerosis. It is your gate. It is your lock to your house. You have keep the door open and you think nobody will come in. So if your HDL level are more than 45 in males and more than 55 in females, you will never develop atherosclerosis, whatever your LDL levels are. So basically, the best is to keep your LDL less than 100, HDL more than 55 in females, more than 45 in males, and cholesterol 150 and triglyceride 150 is the ideal. Diabetic management, if you keep HbA1c below 6.5, no exact control is required. You are very happy in managing your diabetes. Smoking totally curtailed. Tobacco has totally to be stopped. Now comes the physical activity. At least exercise for 30 minutes minimum per day. 5 days a week is sufficient. You can take rest on your weekends, or you may use weekends, take rest on your busy days. This is very important. Now, what type of exercise? There are 3 components of exercise. One is isometric, isotonic. Now, you have to do weight training, a small amount of weight. You have to do brisk walking. And third, you have to do stretch exercise. If you have all the 3 things in your exercise, you will tend to have no problem. Now, the best is yoga. Go for Surya Namaskar, stretch exercise. Walking, you have exercise of your legs and arms. And third, weight training. We have muscles which will not sag with age. Now, coming to assessment. Once you have assessed everything, you have a guideline to the patient, you give them a diet. It should not be a strict diet. Let them eat everything. Never go on unnatural things. Never go on protein products. Never go on packed items. Go on natural things. Always nature provides the food which you require at what time. So that is very important. Now, this preventive aspect has become a very big goal in last 3 years. And now most of the conferences we are having in cardiology are having only preventive cardiology. Initially, we were discussing angioplasties, we were discussing stents, pacemakers, electrophysiology. Now we have more of preventive cardiology. Now it's a conglomerate. You require a diabetologist, endocrinologist, you require an internal medicine physician, and you require a cardiologist to go for it. Now we have various trials, 10 breaking trials which have come. Now most important is those patients who have a LDL-C cholesterol of less than 70 for 12 years, they have a very low risk of developing atherosclerosis. Lot of drugs have come. The latest is movalepilin, which you must not be knowing, the only drug which is effective in decreasing lipoprotein A. We didn't have any drug till now because lipoprotein A is genetically determined. It is a bell-shaped distribution. Lower limit is 30, upper limit is 90. And if you have a higher lipoprotein A, we call it little LPA, the atherosclerosis increases 5 times faster. Similarly, we have a lot of trials which decreases LDL. Now, we have a drugs which are antibodies like Recta-Civimab. These are basically, you inject them intramuscularly once a month. Cost is whoopingly high. It costs 28,000 for a single injection. Very effective in familial dyslipidemia, homozygous dyslipidemia. Drugs are not controlling your LDL and cholesterol level. Now, you can give 3 doses. Patient will continue to have decreased LDL for almost a year. Now, they have another drug which has recently come, which is now available in Indian market also, is Bemitride, which is a very effective drug. It can be combined with statins and can be used. It has an additional effect in reducing your LDL. Now they have come out with a new scoring system. Initially, we used to score with hypertension, diabetes, dyslipidemia. Now, Score 2 is a system where they have included patients from 45 to 70 years. We do not include any of the disease. We only include non-risk factors. What is their lifestyle, what they are eating. And this is on basis of this, we will see into the preventive aspect of this. So this is a new Asian score which is developing, especially in the Middle East and Southeast Asia, to assess for it. Now we come on to the next, how this machine learning has caused to understand the system. You put the data into the system. Now we have various trials, if you remember, Flamingo trial, progression of early subclinical, Argan health workers, Framingham Arm study. Now what they did was they put all the data into the artificial intelligence and ML. And surprisingly, they found that this data can be interpreted much better, in a much better way. So basically, artificial intelligence coming future will help you much. When we are talking of primary prevention, we are talking of control of blood pressure, diabetes, hypertension. When we are talking of secondary, once a patient develops a heart attack or develops angina, we are talking of secondary prevention. But can we diagnose it much early and prevent it? Yes. You can get your CT angiography done at the age of 35 years, see your calcium score. If your calcium score is 0, your risk is very poor. At 40 years, you can get a CT coronary angiogram done, non-invasive test, see for the plaque. You can see for the plaque morphology. If you think you have mild stenosis, start your preventive aspect and you will find that you will be free of a cardiovascular disease. Now, important advances in recent advances in cardiology in last decade, recent cholesterol management guidelines have changed. Now we want LDL cholesterol to be 50. Initially, it was 70 in patients who have coronary artery disease. And in normal person, the shit has to be 70. New antihypertensive guidelines, BP has to be 120/80. Anything more than 120/80, you are pre-hypertensive. Once you become 140/90, you come in the range of blood pressure. Emergence of new diabetic therapy, this will help in reducing cardiovascular mortality. Now, hypertriglyceridemia, which used to be thought is not a risk factor, is considered a risk factor. Inflammation hypothesis of atherosclerosis. New perspective in women and heart diseases. Initially, we thought that menstruating women who are having periods will never have heart attack because they have high estrogen level. But now we are getting even patients who are less than 30 years, 35 years, and they have a terrific blockage. Probably because of use of oral contraceptive has become more frequent. That is one of the reasons. Change in the dietary habits, stress level. Then development of PCSK9 inhibitors, we have already discussed, which can be given intramuscularly. Now, what we are talking now basically is a mRNA, messenger mRNA interference drug. This is the latest concept. If you directly block mRNA, it will probably be more effective and will prevent the disease process, will prevent the progression of disease, and will block the disease. Now, what we have missed opportunities. What basically we should look now? Failure to get the risk modification. I talk to my patients, he's still smoking, he's not controlling his diabetes, not controlling his blood pressure. Failure to elicit and follow people's goals and needs. He is not up to the mark of BP control is not there. He misses the drug, compliance is fear. Or I have a failure to diagnose. I'm not able to diagnose the disease. Patient is in minor heart failure, diastolic. I do an echo. I treat him. He's okay. He's fine. Because of the misdiagnosis, probably these patients may develop in future the problem. Now we are not using the appropriate drug. We are not going according to the guidelines. So guideline says in heart failure, you have to use RD, you have to use aldosterone antagonist, you have to use beta blockers, you have to use diuretic. You're not using all. So what basically, you are pushing the patient to go into more heart failure. Now, we are not using advanced treatment because we are not aware of this. So you have to keep your breast with the latest technologies, latest machines. Send to a super specialist so that he can advise you better. Patient can come back to you. But this is the advice we have to give. Failure to provide a supportive care. Patient is poor, you prescribing costly medicine. So you have always to look in whether the treatment what you're giving will fit to his conditions or not. So this becomes very important. Now, in summary, what I want to basically tell you is, it is not the practice of cardiology what you are doing. It is not that I perform angiograms, do angioplasties, and pacemaker. You have to look whole as a patient. You have to understand the problem. If you go to buy a house, you look from the exterior of the house, see the paint and come there and sign the deal. What does it mean? You go inside and the rooms are all shattered. There is no bathroom. You have no place to go. Then what will happen? So you have to assess the patient fully. You have to decide what drugs to be used in what patients. Are you using evidence-based medicine? Now, be abreast with the clinically data which is coming up rapidly, daily changes. Make habit, read at least 15 minutes daily in the night. And the best ways, rather than reading unnecessary things, whatever you read will fix in your memory and will help you. Enormous opportunity exists for us to prevent diseases which are coming up, and probably your support, your guidance in future coming births will help to really help the coming up generation to prevent this disease. A marked opportunity exists, and thank you very much for a kind attention.
Thank you, sir. This was a very informative and indeed an insightful session. I hope our young minds have learned something today. And if anyone has any doubts, you are please requested to ask your questions. There's a doubt. We are having there a doubt. There. Please give it mic to him.
Hello, good afternoon, sir. My name is Kana Sharma. I am from AIP.
Yes. Yes, please.
Hello, good afternoon, sir. Sir, my name is Kana Sharma. I am from AIP and I am third year student. So my question is, my father takes the medicines for hypertension daily. Should he take likewise? Because as we know, every medicine has certain toxicity. So if we are taking that medicines on daily basis, does it mean we are damaging our heart gradually? So my question is, sir, can we take medicines in some longer intervals of time, not on daily basis? Or can we take medicines when we feel uncomfortable?
See, you understand you have three aspects of a question. Your father is basically hypertensive, so you need to control your BP. Now, when you have hypertension, you have three damages: lung, pump, filter, and pipe. Pump is your heart. If you continuously high BP, your heart will hypertrophy. So you are teasing your heart. Second, filter, kidneys. It will damage your kidneys. So if your BP is continuously at damage, pipes, your retina. So you will have damage to the retina, small arteries. So you have to manage your blood pressure continuously. Now, when you go to a doctor, he prescribes a medicine. Target should be to keep the BP 135 systolic less and less than 85 diastolic. If he is not able to control full dose of one drug, he has to add another drug. This should be the target of BP. We have combination of drugs to have good compliance of the patient. So you have one dose of the drug. Preferably, most of these pustules have a night rise in blood pressure. And the maximum BP of a patient is in the early morning from 6 to 10 a.m. If you do a monitoring of the blood pressure, patient has to take the BP. Now I'll tell you example. What are the drug effects of? Now you have to assess the patient, which patient needs what drug. If the patient has got a kidney disease, he has got a renal artery stenosis, bilateral, you cannot use ACE inhibitors, you cannot use ARBs. Now I'm using calcium channel blockers, dihydropyridine especially. They will cause edema of the feet. So what I have to do, I have to combine a drug so that the less dose of dihydropyridine is used. Still, the best drug is amlodipine because it's a anodonor. It prevents atherosclerosis and it controls the BP. It can be used in LV dysfunction, the only calcium channel blockers. It does not cause reflex tachycardia. So till present, whenever you start a drug, you have to start. Now a young guy comes to me. He has to appear for exam. He has a family history of hypertension. He is only 26 years old. I'll never give him amlodipine. Now my choice of beta blockers will be probably bisoprolol, because that will not cause him memory disturbance also, and will control his blood pressure. So you have to assess which drugs to use in which patient. Always use drugs. You can ask questions to your doctor. Why are you using this drug? And remember one thing, every 6 months, kidney test is important for a hypertensive patients. Always assess. When a doctor writes, he will find a secondary cause. Number one, whether the kidneys are working, kidneys are damaged or not, it is affecting the heart. So he requires to do 3 tests, a ECG to see for the hypertrophy of the heart, kidney functions, creatinine and urea, and fundus examination for the eye. If he finds LVH, he can go for echocardiogram. Any more questions? Yes, you can ask. I'll be happy.
Thank you, sir.
So this will give you more insight into the lecture. You keep on asking.
We highly appreciate the questions asked by Mr. Khanna.
Yes,
Good
please.
afternoon, sir. This is Sandesh Pandey from Jay Institute of Pharmaceutical Sciences and Research. Sir, my question is this. My grandfather take Metexcel 3D. In Metexcel 3D, tell me certain
I
and
know the combination. You carry on. I know.
okay, sorry, sir. So it is good or not? Because my grandfather also take amlokine 80 also.
No, see, you cannot combine 2 beta blockers. It already had a Maxetil 3 as metoprolol. And amlokine is retinol. So you cannot combine 2 beta blockers.
But they eat both. It's not good, na?
It's not good. You cannot combine 2 beta blockers. You can increase the dose of the same beta blocker. So if now what is happening is you ask your doctor to check for pseudo hypertension. I'll tell you what is pseudo hypertension. When you age beyond 70 years, you get systolic BP more because of arteriosclerosis which occurs in the artery. So what he has to do is he has to see for the target organ damage. If there is no renal involvement, no fundus involvement, ours is not hypertrophied, he is probably dealing with pseudo hypertension. Now, because you are all pharmacists, I'll tell you a very good thing. If you have a systolic BP higher, systolic means upper BP higher, then the drug of choice is only 2. You have to use calcium channel blockers or you have to use diuretics. No drug will decrease it. But if you have a diastolic BP higher, then you can use beta blockers along with other drugs. Now, what the problem occurs is patient comes to you. Most of the doctors are being taught by the pharmacist. So this is the new drug. They will jump into that. So you have to understand what drug is to be used in which patient. Now you stop your grandfather, put him on 10 milligram of amlodipine, 100 milligram of metoprolol, and a diuretic, what he is already on, hydrochlorothiazide 12.5 milligram. This will be the best combination.
And next question is, sir, normal blood pressure in during, मतलब आजकल के condition के हिसाब से normal blood pressure कितना होना चाहिए?
See, if you are more than 60 years, then you have to keep your BP less than 140/90. But if you are less than 60 years, your BP has to be 120/80. I told you the normal BP is 120/80. When you become between 140/90 more and between 120, you are pre-hypertension. Like pre-diabetes means you are in a hypertensive level. So whenever you are treating, your BP patient has to be of less than 135 systolic, 85 diastolic, because all trials all over the world have proved once the BP is lower than this, then only you can give benefit to the patient. See, if you are treating a patient 120, 180, 120, he comes to it with 160, 100. Don't be happy because he's still in the range where he's hypertensive.
Thank you, sir.
Any more questions? You keep on asking, it will benefit you. Yes.
Sir, may I one question from here? Sir?
Yes, please.
Sir,
Yes.
Sir, this is Dr. Jovita Kanodia. One question, sir. There are so many advertisements over the cooking oils, which are totally telling they are very heart friendly and all. So what is your suggestion? What kind of oil we have to choose for the patient who is having high lipid profile? How to take care of their heart by using oil? Either some are telling clarified butter is good for the heart patient. So what is your opinion and suggestion, sir?
Come on the podium and talk. That is a very good question. See, this is an excellent question and it was asked most of the forum. Number one, what oil should be used and what the quantity. See, basically, anything which freezes as room temperature is not to be used. First, remember, any cooking media which freezes as room temperature is not to be used. Room temperature normal, we consider 28 to 30 degrees. So we cannot use because it is very rich in saturated fatty acids. So this is out of question. Now we come to the oils. We have to look into the oil which are more of omega-3 fatty acids, because omega-3 fatty acids are responsible to prevent atherosclerosis and they increase your HDL level. All the cooking media, once you warm them, they become hydrogenated and they become toxic. So all the people who are sitting here, when you go home, tell your parents, or if you are cooking, used oil should not be reused. This is one fundamental. Now, as she was asking which oil to use, all oils are good. Whichever oil you want to use, it depends on your taste. Now, whether we can use ghee, this is another question which will be asked. Yes, you can use ghee, but the ghee has to be of cow milk origin because it's rich in omega. You cannot fry anything in ghee. It has to be put on the chapati because omega will get destroyed. And how will you realize this is a good quality ghee? It is yellow colored because omega looks yellow. So basically, don't go on any advertisement that vitamin A is added in this, vitamin E is added. Can you think when you heat up, any vitamin can sustain? You're not going to drink that oil directly. So if you go abroad, most of us have traveled, you will find they do not cook it. They do the dressings of the salad by putting olive oil. They steam the things, then they do the dressing. So basically, you're not heating up the olive oil. So all our omega, all the essential, they convert it into hydrogenated fat, which is basically causing atherosclerosis. इसीलिए जो तुम लोग समोसा कचौड़ी खाते हो ना, वो रात में तेल रखता है, अगले दिन उसी को गर्म करके बनाता है. And that is responsible for most of the damage. Natural things are very important. Good question. Any questions? Another
yes,
thing I
sir.
want
One
to
more
add.
question, sir. One more question.
Myself, Dr. Neeraj Mishra, and I
Please.
want to ask suppose a person taking the calcium supplement daily, then is going to damage for their heart or some kidney stones?
No. See, whenever you are taking calcium supplement, it's to be taken after full meal. Remember one thing, because once it gets absorbed with your food, it will not cause problem. But a calcium supplement does not required by a normal individual. Why? I'll give you a large study trial which was conducted between doctors and LNCP students of the same age. LNCP, you know, is a physical college. They found that the girls who were exercising, because they were exercising, they have zero osteoporosis. And doctors who were intermittently taking calciums were found to have osteoporosis. So basically, body has enough calcium, which helps you in metabolizing and forming new calcium and absorption. So if you regularly exercise, give good amount of vitamin D. How do you get vitamin D? Early morning in the sun. In summers, 5:45 to 6:50. In winters, 7 to 7:30. This is the time. You should give some amount of sun to your body. It is the most healing. And that is the reason they say that you should give argha to the Surya. It is nothing. You are taking vitamin D. So this is most important for calcium. But try to avoid calcium until unless you have low calcium.
Thank you. Thank you, sir.
Yes.
My name is Professor Mayram Singh. I want to ask a question. What is the role of nutrition in heart disease management, and why use diuretics for cardiovascular diseases?
See, nutrition forms the mainstay of therapy. I'll tell you good example is that what you should eat in breakfast should be a rich source of minerals, nutrients, and omega. Now, what a normal person takes? Normal person will take, what he will take? Samosa, kachori, khapne ka liye, jalebi kha liye. No. You should take nuts. Nuts basically are a very rich source of omega. Almonds, you can take 10 almonds. Then you can take मूंगफली के दाने, roti, and you can take dalia and dal. This should be a basically take a very heavy breakfast, because at that time your body needs the maximum energy. Lunch should be less than that and dinner should be the least. They say भूखे की तरह आप वो करिए अपना ब्रेकफास्ट, नॉर्मल आदमी की तरह लंच, और राजा की तरह रात का खाना मिनिमम, and should not eat after 9. Try to avoid eating after 9. When you go to bed, at least you should have a difference of 2 hours between a meal and bed, because it has a dumping effect. It will increase your sugar level and simultaneously it will increase your atherosclerosis. So these are the normal. Always take the nutrients and the fresh fruit which is available in the market of the season. I'll give an example. Tarbooj is available in summers. It contains 90% water. Kharbuja is available. It contains 60 to 70% of the water. Vegetables which are available are basically for seasons. In winters, we have amrut. It's a very rich source of antioxidants, very rich. Bear you get in this season, very rich source of antioxidant. Now you'll find that blueberries, blackberries, you are buying 1,000 rupees kg you are buying. इससे अच्छा 10 रुपए किलो के बेर खरीद के खाओ ना, उससे ज्यादा एंटीऑक्सीडेंट्स. So we are going into the system which is making us bad. Eat the natural product. Ask your mother. उसी समय आटा गूंद के खाएंगे आप, it will be better. I'll give you a concept on nutrition. There's a nutrition, live food and a dead food. What is live food? Live food means I'm eating the food which has just produced. आप उसको अंकुरित दाल, मोट, मोंगर, चने, सोयाबीन, खड़ी उड़द खाइए. उसी समय आप आटा उसनिए, उसकी रोटी बना के खाइए. लाइव फूड. आपने आटा उसना, योर पेरेंट्स आर बिजी, यू आर बिजी, आपने रख दिया फ्रिज में 4 दिन, वही चल रहा है. आप ब्रेड खा रहे हैं, इट इज डेड फूड. ट्राई टू ईट लाइव फूड. सी यू हैव टू चेंज योरसेल्फ. Why we are getting into this system is because of our habits. Any questions more? This is a good question.
सर मेरा क्वेश्चन थोड़ा अलग है. आप डायग्नोसिस में you have just explained the role of AI, and this is a very near treat. People are having question of treat that if this AI will involve in medical practice, then the results will be not good. So how you estimate or how you just rate it, the percentage or amount of AI which should be mixed with the medical practice?
See ये तो ऐसा सवाल पूछा है कि खरबूजा चाकू पे रह गया, चाका खरबूजे पे, कटना तो खरबूजे को ही है. So basically the problem with AI is whenever you have development, it has some bad things. I'll give you an example. When the ECG AI came for the first time, ECG we used to report. अब क्या होता है कि आपके पास मशीनें आते हैं, इसमें डायग्नोसिस लिखा आता है ऊपर, साइनस टैकीकार्डिया, साइनस एरिथमिया. Now what is happening is अगर पेशेंट हिल गया, हाथ हिल गया, कंपन आ रहा है, तो वो उसमें लिख देता है एट्रियल फिब्रिलेशन एरिथमिया. So this is the problem of artificial intelligence here. वो उसकी जो प्रेजेंट सिचुएशन है उसको डिवाइड नहीं कर सकता. जैसे मैं आपको एक एग्जांपल दूं, डोंट टेक इट अदरवाइज. somebody has long hairs, मेल, वो चुटिया बांध के पीछे से खड़ा है, आप उसे सीटी बजा लड़की समझ के, वो घूम गया, तब आपको समझ में आया लड़का है. तो दिस इज बेसिकली AI. This is basically AI. So what you have to understand is that you have to understand where the AI is useful, where it is not useful. Nobody can outright human brains, because AI is also produced by humans. Nobody can outright human brains. Just for 30 seconds, I'll give you a story. You are reading this time that they will, with AI, they imitate the voice of your child. And they will say that we have kidnapped your child, and your child will be talking, Papa, mujhe inne. You are getting a lot of. Now, what is how to get out of this? It's very important. Whenever you are children or you are there, even you can be kidnapped, don't bother. So you tell your parents, जब तक मैं 3 बार राम नहीं बोलूं, ये समझ जाओ कि मैं नहीं बोलता. So you should have a code word. Any code word you produce, अपने भगवान के नाम से बनाए, अपने mother father के नाम से, until unless you speak that code word, you know that your child is not speaking. So this becomes a very important. AI is fraud. Even somebody may produce my voice and ring you कि मैं ये बोल रहा हूँ आप आ जाओ. This is very, very, you have to be very clever now. So AI is a double-edged sword. But human brains are more faster than AI. So as I tell you, you have to understand AI. Now I'll give an example. BP instrument, most of you have in the house. Now tying of the BP instrument is very important. If you don't tie it correctly on the medial aspect, the sensor, it will give absurd reading. So now we get a lot of patients. अब मेरा BP 70 रह गया है, मेरा BP 200 दिखा रहा है. So basically you should know how to use it also. So these are the two aspects of the things which you to understand and which, so AI is a double-edged sword. You have to understand it. And as very well said, it will really have problems in the coming future to have to be very sharp to understand. Any more questions? But answers are more interesting than lecture. Thank you.
Thank you, sir, for enlightening everyone. I now would like to request Honorable Pro-Chancellor and other dignitaries as well to kindly felicitate Dr. Puneet Rastogi. Sir, please. Thank you. Thank you,
so
sir.
much,
Thank you,
sir.
ma'am.
Ladies and gentlemen, we hold the proceedings as of now for lunch. Dignitaries are requested to head towards VIP lounge for
Kindly be
lunch.
seated for a while. Please kindly be seated for a while.
Please be seated for a while. Delegates are requested to move towards C block foyer for the lunch, and Amity students are requested to move towards mess.
H2 mess.
H2 mess. Students and participants are requested to
Come back here after 30 minutes. Do come back after 30 minutes. We are going to have our next technical session by Dr. Ratinder Jhaj.
Amitians, please move towards H2 mess.
At 2:30, we are going to have our second technical session. 2:30. Excuse me, everyone is requested to be back at 2:30 for
Sharp.
the second technical session. चलाते रखिए 30 minutes ही है नहीं तो फिर आके अरेंजमेंट करना है ऑल दोस इट्स बेटर कीप लाइक दिस हाँ वहाँ पे आई थिंक जरूरत तो नहीं होगा अभी हाँ हाँ साइन करना चाहिए अब यहाँ पे रहते हैं तीन चीजें हैं ये दो माइक हो गए ठीक हाँ
जल्दी से आ जाओ, तब हम लोग जाएंगे जब तुम लोग आओ। उधर सामने सामने नहीं, उधर Okay, okay. if you have this much space is okay now. Table is backside. You just one seat. एक बार पहले से देख लीजिए तो टेबल आपके लिए sufficient.
We have to highlight 2 minutes.
Good afternoon. All the students are requested to occupy the front seats. Not the front row, but after that. Yeah.
Good afternoon, everyone, and welcome back to our next technical session. Proceeding the session further, it's our pleasure to introduce our resource person, Dr. Ritinder Jhaj, MBBS MD, DM, Professor and Head of the Department of Pharmacology, All India Institute of Medical Sciences.
Dr. Jhaj is currently working as Professor, Department of Pharmacology, All India Institute of Medical Sciences, Bhopal, and Coordinator, Regional Training Center in Pharmacovigilance for Madhya Pradesh and Chhattisgarh, cum ADR Monitoring Center, AIMS Bhopal, under the Pharmacovigilance Program of India. She received her MBBS from Christian Medical College, Ludhiana, MD Pharmacology, Silver Medal, and DM Clinical Pharmacology from PGIMAR, Chandigarh. Her areas of interest include pharmacovigilance, antimicrobial stewardship, prescription and research, pharmacogenetics, and pharmacoeconomics. In 2023, she received the Excellence Award in the field of clinical pharmacology by South Asian College of Clinical Pharmacology, Bhopal. She has published 56 articles in PubMed Index journals and several book chapters in the field of clinical pharmacology. She is the member of Core Training Panel for Pharmacovigilance, member of State AEFI Casualty Assessment Committee, member of Institutional Animal Ethics Committee, AIMS Bhopal, member of Core Tuberculosis Committee and Maternal Death Review Board, AIMS Bhopal. She is also the life member of the Society of Pharmacovigilance India, International Society of Pharmacovigilance, Indian Pharmacological Society, Forum for Ethics Review Committee of India, and South Asian chapter of American College of Clinical Pharmacology. Now we are handing over the stage to Dr. Ritinder Jhaj for her session. Ma'am, please.
Good afternoon, and yeah, thank you once again to the organizers. And actually, there's another thing I want to thank the organizers for is for my promotion. Actually, I am a professor of pharmacology at AIMS Bhopal, but I'm not the head. The head is my husband. So in home department, I am the head. So you are not too far from the truth. So it's okay. How do I change the slides with this? Okay. Yeah. Thank you. So now my greatest challenge, I'm happy to see at least this much of the delegates come back. This is the usual scene at conferences. The rest, I think, have either gone off to sleep or sightseeing. So my challenge will be to keep the ones who are back awake. I'll try to do that. So this talk is very basic. In fact, it's not even core pharmacology. And I don't know whether I should thank Dr. Naveen for that or not, because it made me read certain things like taxes on tobacco, which I didn't know kitna hai, which I'll be asking you down the line. Right. So anyway, actually I do thank Dr. Naveen for taking me outside my comfort zone of pharmacology. And this is more of a community medicine talk. Okay, anyway, I talk too much. So let me start the topic. So this is what I will try to cover, or I should say uncover. So basically we've already, and a lot of things actually Dr. Puneet has made it easy for me. He's already been talking about a lot of preventive measures for cardiovascular pharmacology. So I will still touch upon the CVD burden globally as well as in India, and also how the CVD burden in India is more than the global CVD burden, probable reasons for it, and of course the most important part is how to reduce that burden. I don't know if this, can we have those lights off? Is it, even those lights, I don't think we need them. I don't think it's visible otherwise. So anyway, a few of the initial slides are going to be again full of stats of cardiovascular disease. Now, this global burden of disease is actually an international study group which covers, as of now, 204 countries and is, gives epidemiology of various diseases, not just cardiovascular disease, all over the world. In fact, so as you can see here, cardiovascular disease is the leading cause of death globally right now. And the prevalence in 2015 was 422 million, but now, in fact, the latest results have come out for the global burden of disease. 2019 results have come out, where they show that the prevalence of cardiovascular disease is as much as 523 million worldwide. And out of this, a large proportion, 2/3 to 3/4, is in South Asian countries like ours, like India. I won't go into the global death rate. I'll now come directly to India. Now, there has been what we can call an epidemiological shift over the last 10 years, or you can say even the last 30 years. A country like ours, developing countries, till recently we used to think, okay, we are a country where we get more of TB and leprosy and tropical diseases and other infectious diseases. But that is no longer true. Since the last 30 years, it has been seen that we are having more of the non-communicable diseases. Not just cardiovascular, but other non-communicable diseases, including cancer, is more now in India and other underdeveloped and developing countries rather than the developing world. So as in this pie chart, anyway, even if you can't read the figures, that's okay. What this shows is that 60% of the mortality over the last few years has been due to non-communicable disease, and 26% of total mortality has been due to cardiovascular disease. So 26%, 1/4 of the deaths are due to cardiovascular disease. This again, shows what I was just saying. So cardiovascular mortality in India is second only to China. Now, these are the number of deaths. So obviously there will be more because our population is more, right? But also this shows that we are, moving ahead in somewhere in a field where we should not be, that is in cardiovascular mortality. So I've already talked about the global burden of disease group. You can ignore that, but even the risk factors for cardiovascular disease like hypertension and diabetes, you all know, I think we've all heard the phrase, India is the diabetes capital of the world. So that is really true. So this International Diabetes Federation Atlas study, that has shown that there are nearly 73 million people living with diabetes in India as of 2015, which is second again only to China. Hypertension, we have 207 million people living with hypertension. That's according to a fourth district level survey, which was finished in between 2012 and 2014. And what is projected is, so all this disease burden leads to disability, mortality burden, but it also leads to cost burdens. And what is projected is by 2030, this is going to cost us more than $1 trillion in healthcare costs. So that is another thing that we have to be careful about. And as I said, hypertension, diabetes are risk factors. So this, if you can see, I'm sure you can't read the figures, but we being in Madhya Pradesh, so Madhya Pradesh has a prevalence of both hypertension and diabetes about 18 to 20%, which is a huge, huge prevalence. And most of the patients who are diagnosed with hypertension are not an ideal treatment, and their blood pressures are not fully controlled. Now, this is not something that, it's peculiar to India. This is worldwide. The problem is that not all patients of hypertension are either under treatment, or even if they are under treatment, they may not have achieved their target hypertension or blood pressure goals. Now, so that was again slightly maybe a grim picture, depressing picture, and I had promised to keep you awake, but I'll still try to do that. Now, the thing is, cardiovascular burden is not only higher in India, it is also a little different in India compared to the rest of the world. So we've already talked about higher relative risk burden. In addition, what is happening is that we are, as Dr. Puneet was also talking, that we are having, patients dying of MI, acute myocardial infarction, heart failure, much earlier than before. And this has been shown in studies. The mean age of getting the first MI is lower in India. The mean age is 53 years old compared to 58 or 50, nearly 59 globally. Similarly, the death rate in India due to CVD is more than the global death rate. That is 282 deaths per 1 lakh patients with CVD. compared to 33 deaths. That is 50 deaths more than in a lakh population compared to the global figures. And also nearly 2/3 of the deaths, cardiovascular deaths in India, premature. Premature meaning less at age less than 70 years here. So that is something peculiar to India. Now, what is the reason for this peculiarity? Obviously, we don't know all the reason. So if you can, see from this figure, the changes or the differences can be at the population lifestyle level, or it can be increased biological risk. Now, I'm not going to go into all of these, obviously, but if you can see, there are 6 major transitions that have happened over the last maybe 20, 30 years. So one is epidemiological transition, which we've already discussed. That is, now instead of more infectious diseases, we are having more of non-infectious diseases. We are developing, right? There is a demographic shift. That is now because of better healthcare, more people are surviving into their elderly or old age. So there are more cardiovascular diseases happening. Environmental shift, that is, we are also pollution. Some of our cities like Delhi are also the most polluted cities in the world. So in fact, that's one area of research in cardiovascular disease that is now thought to be neglected, but also thought to be interesting area of research. Effect of pollution. So pollution affects not only respiratory diseases, it also affects cardiovascular diseases. So you could do that. You could even study the effect of air pollution or even noise pollution on cardiovascular risk because of the stress caused by noise pollution. A socio-cultural life, we are now, again, I think as Dr. Rastogi was saying, we follow sedentary lifestyle right from childhood. Parents, to keep their children busy, they'll give them their mobiles and iPads, and students, all of us, and now we have this Netflix on laptops and mobiles. So we are following sedentary lifestyles, ordering pizza, or eating more calorie rich foods, which is affecting our nutritional. So there's a nutritional transition away from our healthy Indian typical food. We are having our burgers and pizzas. And also the economy, our economic situation is allowing us to do that. It's because of our better economic situation that all of you, I'm sure, is there anybody who doesn't have a smartphone in this? None of you. So all of you have smartphones. And if I were to ask you, anybody spends less than 5 hours on your phone? You do? That, yes, that's so. But you see, in maybe how many 200, there are only 3 hands raised up, right? So we tend to be sedentary, fixed to our mobile phones, and anyway, so that's the lifestyle transitions that are happening now. There are also some inherent biological differences, probably amongst Indians. We haven't still understood all of this. We are still trying to understand. And for this, of course, we can't blame ourselves. So there, as I said, and as you already know, India is a diabetes capital of the world. So it's not just because, we are eating more or exercising less. There may also be some genetic differences in our glucose metabolism that is making us more prone to diabetes. So let's not blame ourselves for everything. Similarly, the body composition, Indians tend to have more visceral fat. So when the same weight, if there is an Indian and a Caucasian or a white person, the visceral fat is more. And you all, I'm sure, aware that visceral fat is the fat that is more dangerous where insulin resistance is concerned. So visceral fat leads to insulin resistance and diabetes, which in turn is a risk factor for cardiovascular disease. Similarly, our lipid metabolism, we tend to have lower HDL, like you already know. be useful. And this is what we have to try in our country too. So I'll try to, discuss these a little bit. Now, and all these have to be, done at various levels: primordial, primary, secondary, as well as tertiary. Now, primary, secondary, tertiary prevention, we have all heard. What about primordial? Can anybody say what is primordial prevention? I heard one of the other keynote speakers also mention this term, but do you know what it is? So we know, so what is primary prevention? So I'm just making sure that you're still awake after that nice lunch. Primary prevention? Try answering primary, then you'll know what is primordial. So that is primary you're talking about? Yeah, so primary is when we know that somebody has a risk factor, we try to take some measures and prevent the disease. And you're very right. So it's nutrition, exercise. So, and what is primordial? So primordial, obviously, even from this slide, you can understand it comes before primary. So you said diet and exercise, that takes care of the obesity, the diabetes, right? Which are actually the risk factors for CVD. So, and in fact, so this is nothing but primordial. So when you are doing something to prevent the risk factors, that is primordial, right? So anyway, that will come into my slide. I'll come to it when I come to that slide. Now, before that, I'm really sorry for this poor contrast. I don't know how much you can read it, but anyway, so before that, before I go into all those types of prevention, so how are they being addressed in India? What is the government of India doing? Now, since 2011, I'm sure all of you have heard of that there is what we call a national program for prevention of non-communicable diseases, which includes not only CVD, it also includes cancer and diabetes. Okay, diabetes, which in itself is a risk factor for CVD. So this was launched in 2010 in 100 districts in 21 states, but now it has been spread all over the country, and it has been merged with the National Health Mission. That's really strengthened the program. So under this program in primordial prevention, so primordial, as I said, is you prevent the risk factors. So obesity is a risk factor for CVD, you prevent obesity. Decreased physical activity is a risk factor for CVD, you prevent decreased physical activity. That is, you educate people about improving their physical activity. So just let me go into the, risk factors. So you all know smoking or tobacco use in any form, including pan, is a risk factor. Unhealthy diet, we've already discussed that, is a risk factor. Alcohol consumption is a risk factor. Physical inactivity. Now, these are behavioral risk factors, which we can, or what we also call modifiable risk factors. This, if you make the patients or the population, not even patients, they are not patients, right? Yet, okay, they are people. You make them aware, they can change their habits and their lifestyle. So they do not consume alcohol, they are more physically active, they do not smoke. Okay, so we are preventing the risk factor itself. Then there are some, what we also say intermediate risk factors is actually raised BP or impaired glucose tolerance. That is, you might be having hypertension or just raised BP, dyslipidemia. And again, if you can prevent these from happening, okay? And anyway, that's not a risk factor, that is the end result. So any measures that prevent these risk factors happening are called primordial measures. So this is again, if that slide was not clear enough, probably you can see the all 9 important risk factors: smoking, hypertension, high blood glucose, cholesterol, diabetes, obesity, unhealthy diet, etc. Now, so how can we address this problem? Now, WHO actually has this publication, which is available as a PDF from Google, which is Health Priorities. And sorry, not WHO, the World Bank actually has, published this package of activities or interventions that can be done for primordial prevention. And this is where, as said, that Dr. Naveen, yes, now he is here. He forced me to read up a little. This is the slide where I had to read up a little. So what are the measures that the World Bank has recommended is, first of all, tobacco. So we want to prevent the risk factor, right? Like tobacco smoking or unhealthy diet. So they have many countries, smoking is banned. In India, of course, we don't have that, but we have taxation on smoking. Right. So can anybody say what is the taxes on cigarettes or tobacco products in India in the GST regime? General knowledge. Okay, what is the highest GST? Yes, 28%. So that is the tax on. So the government of India has increased the tax on tobacco and tobacco products, right? On sugar sweetened beverages. Okay, beverages where, are also a huge reason for increased calories. All your Pepsi and Fanta, they have a lot of sugar added. So there is an increased taxation on that. What about fats in foods? They are also, what are trans fats? Like again, somebody had asked about oils, and Dr. Rastogi was saying the fats that actually on room temperature they solidify. So they are rich in cholesterol, and they are usually added to snacks, these ready-made cakes and biscuits to increase their shelf life, and they're a huge reason for unnecessary calories. So in fact, many countries, including USA and UK, have banned those trans fats in snacks. What about India? Have we banned them? Anybody? No. But have we at least limited them? Yes. And what is the percentage? Any guess? So how much, say, when you, and actually why I'm telling you this now, when you are buying, say, cookies or cakes, those Britannia, no, okay, let me not name a brand, any cookies and cakes, you should look at, they do give the compositions, so you should look at it. And that is how you'll remember. Same thing about medicines. I tell the students, look at tablet strips and see what are the strengths. That way only you'll remember. So it's less than 2%. In India, I think this has come about only in 2022. So the government of India has said all these snacks should have, including chips, should have less than 2% of trans fat. So the government is trying to do something about that. Improved build environment. Okay, I won't go into that. School health programs. So we do have school health programs to make children aware about, increasing physical activity. And that formally, I think, has started in 2018. We also have vaccinations and awareness in school. Task sharing and task shifting. Now, what is this? This is something which Dr. Montu Patil was talking about, making pharmacists, training pharmacists to do a lot of the tasks which till now only physicians were doing or even nurses were doing, like educating patients, counseling patients. That is a task which can be shared by or shifted to other healthcare workers like pharmacists, and that would also increase the pharmacist involvement with the patients. In fact, at present, actually, I have an ICMR project where we are doing medication review for elderly patients. And there, actually, so we had this meeting at ICMR headquarters, Delhi, and I actually had argued with them. They had said that it is not scalable in the future because there is no pharmacist to do this in the hospital. And I had argued with them that, of course, but they haven't yet. I have anyway 3 more years to try and convince them that if there are no pharmacists reviewing medications in the hospital, but that is not good. I know there are no pharmacists in a hospital, are mostly only dispensing, but we should have pharmacists. And now that we have clinical pharmacy, and again, Dr. Patil was talking about, increasing their roles. So we should have pharmacists in hospitals who can review the medications and counsel the patients and, teach them about medication adherence, and also check if there is some medication which is not required, or there are drug interactions, or often there are duplications. A patient will go to, say, medicine and cardiology OPD, both, and he may have, say, like, in fact, somebody was telling about their own grandfather, some drug being duplicated. This often happens because a patient will go to different departments and he's getting the same drug prescribed in different departments. Now, if there was a pharmacist appointed in each hospital and not just one pharmacist, I believe there should be, maybe in all OPDs, at least the medicine and allied OPDs, where there is a pharmacist who maybe on demand at least, or on when a patient wants, they can approach a pharmacist, ask, show them their prescriptions for review, and the patients can counsel them, right? So this is something which really can be done by a pharmacist, and a very, very important and relevant role of a pharmacist. But till now we don't have it. So probably PCI, unfortunately now I think PCI members have left, but PCI and NMC, National Medical Council of India, need to sit together and kind of integrate. When NMC makes requirements for a new medical college, I think they should also include pharmacists as clinical pharmacists in the hospital. Anyway, and of course, the other thing World Bank and everybody recommends is screening for these risk factors, because only if you screen, you'll detect them. Only if you detect, you can do something about it. Now, in fact, I'm moving more into these last 2 points are actually primary prevention, not really primordial prevention. Is another very important, and that I have made it bold is because it's related to drugs and pharmacy, is the use of combination pills, or what we call polypill. It is because we know sometimes in India we have a lot of irrational combinations of drugs, fixed dose combination, but this is one combination which is really useful and recommended. That is, it's also called a polypill. It can have as many as 4 to 6 drugs. Usually what it includes is aspirin, 2 antihypertensives, and a statin, which improves compliance. So this is for patients either who already have hyperlipidemia and hypertension, which are risk factors for CVD, to prevent CVD. So as I said, this is actually going now into primary prevention. So these are some of the measures which World Bank has recommended, and which, as you've seen, many have already been, taken up by the government of India. So this is the module for training of medical officers under the National Program for Control of Non-Communicable Disease. And as you can see, so this is now primary prevention. So this is where we find out patients with a risk factor for cardiovascular disease like hypertension, hyperlipidemia, obesity, and treat them. So again, this is a document you can find out online. And here, if you see, chapter 2 is all about screening for these non-communicable disease. Chapter 3 is managing these diseases, that is diabetes, and chapter 4 is for treatment of hypertension. So that's, if we can identify them, treat these risk factors, then we can prevent cardiovascular disease. And here again, one of the important parts of treating them is patient education for improved adherence, and also FDCs, which we've already discussed. Secondary prevention. Okay, again, sorry for that poor contrast. So what is secondary prevention? If you can't read it, it's okay, I can ask you that. I'm sure all of you know. What is secondary prevention? So once a disease has already happened, you want to prevent it from happening again. Okay, so that you are preventing a recurrence. So most of the measures are same. In addition, you also would want cardiac rehabilitation, where we are talking about CVDs. And again, Dr. Rastogi, as I said, has made my task very easy. Cardiac rehabilitation means you educate these patients about now their diet and lifestyle, so that they do not, say somebody who's had an angina or MI, so that they don't have it again. So that is called secondary rehabilitation. And yoga, we are the country, or originators of yoga. So there are many trials. Yoga Care is a multi-center study on the effect of yoga for rehabilitation after an MI in 24 centers. So this showed that there is really a benefit of yoga in preventing a recurrence of MI. Now coming to tertiary. So what is tertiary prevention? If you can't read it again, it's fine, because I can then see if somebody can tell what is tertiary prevention. So tertiary prevention is treating a condition well, according to evidence, what we say, guidance directed medical therapy, that is GDMT, or evidence based medicine, so that the patients have minimum disability. Say a patient of stroke, if you are treating them well, probably he will not have any neurological deficits, or even if he has, then you put him through rehabilitation or physiotherapy so that there is minimum deficit, or you prevent complications. So that is called tertiary prevention. So you are not disease has happened, now you're just treating to prevent the complications, to reduce the disability, and to rehabilitate a patient. That is called tertiary prevention. Kerala has done some very good work in CVD prevention. So they have a registry, acute coronary syndrome registry. So where they have studied, that after implementing these certain, interventions for better treatment of ACS, so they have found that there are at least some improvement in patient outcomes compared to a previous study. I won't go too much into the study. Similarly, so this is a British Association for Cardiovascular Disease Prevention, so which again highlights that the three pillars of preventing CVD are lifestyle management, psychosocial health, okay, and of medical risk management. Now, another thing, who said choose your in-laws? We can choose our in-laws. Again, I think it was Dr. Rastogi. Okay, I'm quoting him a lot. So now he said for the sake of genetics. Now I'm asking you to choose. Now in-laws, how do we choose? We choose through our life partner. So what I'm telling you now is to choose your life partner carefully, and not only for the genetic reason, for the lifestyle reasons also. So somebody said your life partner that you choose is a very important decision of your life, and so many of you are young, so I'm actually giving you that advice. It will determine 90% of your happiness or unhappiness. Your misery will depend on your life partner. And why I am saying it here is, now many of these cardiovascular disease prevention studies which studied lifestyle intervention have shown that when a spouse followed these lifestyle intervention, the other spouse, that is if the husband followed these lifestyle modifications, the wife was prone to follow them better, and vice versa. So not just for genetic reasons, even for lifestyle reasons, please choose your life partners and hence your in-laws carefully. Now coming to, so that was bit about primordial, primary, secondary, and tertiary prevention. Don't worry, I won't talk too long because I have a train. Good news is that I have a train to catch, so I'll leave you all on time. Now, health systems. Now, of course, in this, I'm not going to talk about everything in a health system. All that I will focus on is, since again, this is a pharmacy and a pharmacology conference, about access to essential medicine. So access to essential medicines for cardiovascular diseases and risk factors like hypertension, okay, hyperlipidemias, diabetes should be there. And again, for this, we all know, you're all pharmacies students and postgraduates and faculty, you know that we have NPPA, right? What is NPPA? Yes, yeah. So that is actually not a question to be asking here, but again, just to see how many of you are awake. Okay, and so we have this, which under which we have the DPCO, Drug Price Control Order, and all essential, at least medicines prices are being controlled. And also now there is in the making essential devices list is also being prepared, in which and cardiac stents actually are already under price control, so that there is, patients can afford cardiac stenting, which is the first line treatment for MI. And also you're all aware that there is this Jan Aushadhi scheme to make generic medicines accessible to all. Service delivery, again, I won't talk too much about it. So service delivery naturally has to be improved. In India, most of the expenses of healthcare are out of pocket, and there is poor health insurance cover till now. But now we have this Ayushman Bharat scheme where no, the government is trying to give more insurance coverage to all. And again in Tamil Nadu, so Tamil Nadu, again a state from the south, they have carried out this study called the Tamil Nadu STEMI study. Okay, and they actually, used a new information technology that was partly AI based, ECG machine reading as well as transmission to various centers. And they found that after using it, there was reduced mortality and better outcomes of STEMI. So this was a study of service delivery in a research mode, which showed the benefits of an intervention. So there are more studies like this that we need to be doing. Health policies, so this actually I've already kind of mentioned. So as I said, in India, there are a lot of out-of-pocket expenses. So for that, the government has introduced the Ayushman Bharat policy. Also, the 2017 health policy of India declares the ambition to reduce, cardiovascular mortality by 25%, and also to make sure that at least 80% of patients of hypertension are receiving their treatment. Cardiovascular research, this I think Dr. Rastogi has already talked about research. So we need to do more of cardiovascular research. We have already discussed the risk factors. So now we need to do more research and find out the reasons for these risk factors. That will not only help patients in India, but that could give insights for the global good. And once you've done research, you need to implement it, what we call evidence-based medicine. Okay. So I won't go into all of that. So as I already mentioned, so there are many neglected areas, but this I found interesting, that you could also do research on the effects of the environment, including air pollution, persistent organic pollutants, that is plastics in the environment, how they are affecting CVD, plastic associated chemicals. We leave water in these plastic bottles, which we do not even know what the quality is. We are consuming water and foods from them. And in fact, even the Katzung book of pharmacology mentions that probably the increased incidence of cancer is because of this. And who knows, even the increased risk of CVD may be because of all the plastics that we are using to store our food, to heat our food, as well as what we find in the environment. Noise pollution. How can noise pollution cause CVD? Do you think noise pollution could have anything to do with CVD? Yes, so sudden loud noises or even persistent noises can lead to stress, and stress can lead to hypertension and CVD, right? And even the climate change again could cause stress and be responsible for CVD. Okay, so with that, I come to my take home message. So this is actually no news. We know CVD, that is cardiovascular disease, is a reason for mortality throughout the world. In fact, now the well-developed countries, because of all their interventions, there the risk is coming down over the past years slightly, but we are still on the uphill. So we have to stop it right now. And this can only be done by a multidisciplinary, multi-sectoral way in which all of us are involved. And we here as pharmacists and pharmacologists, can participate, as I've already mentioned, in a number of ways, by patient counseling as well as by taking part in innovative research to find out the reasons and treatments for these cardiovascular diseases. Key references, if you can, anyway, my PPT has been shared. So if you can't read this and if you want the references, you can ask for it. And lastly, I'll just end by saying that don't lose heart, as we are on the uphill, but we can stop it right here. But lose your cigarettes and junk food and the sedentary lifestyle. Okay, so with that, I'll end. I hope at least half of you are still awake after that. And thank you again. And if there are any questions for maybe 5-10 minutes, I hope
Any questions from the student side?
I can answer.
Good afternoon, ma'am. Ma'am, this is Aman Singh Chauhan from AIP. Ma'am, I have a query that how air pollution can lead to CVD. Can you give a brief about this?
Yeah, so as we have seen, inflammatory states have been now linked to CVD, right? So air pollution can lead to inflammatory states, which in turn can lead to CVD.
Thank you.
So it's not just COPD, respiratory diseases, even CVD may be increased by pollution.
Any other student?
I'm so happy people are awake enough to ask questions.
Good afternoon, ma'am. Ma'am, actually, since COVID, we are experiencing major cardiovascular issues. So, do you think there is something wrong with COVID vaccine, or it's just the lifestyle changes that is
Yeah,
causing these
okay.
diseases?
First of all, thanks a lot for that question. I was going to mention it, and we were in fact talking about it. So it could be both, of course, and especially with the mRNA vaccines, thrombosis and coagulation events, including CVT, have been associated. Mostly with mRNA vaccines, but also with Covaxin, which was used in India. COVID itself has led to coagulation events, thrombosis, and MI and deaths. So it can be both. And COVID the pandemic itself led to stress, right, which is a risk factor for CVD. So I would say we cannot rule out any of them. All three factors have contributed to an increased CVD risk.
Ma'am, also, can you explain a bit about silent heart attacks?
Okay, silent heart attacks basically are heart attacks that is lay term for an acute myocardial infarction, where the pain is either not there or less, and this has been seen particularly in patients of diabetes mellitus. So that's another danger of diabetes. You are at a higher risk for CVD, plus you may not even realize that you are having a heart attack. Okay, so I guess there are no more questions. I can catch my train then. Time. Thank you. Thank you.
This was a truly remarkable and knowledgeable session, ma'am. We are grateful to have you here for sharing your knowledge.
Now, for ma'am's felicitation, I would like to request our director, Amity Institute of Pharmacy, and Dr. Naveen Sharma to kindly felicitate Dr. Ratinder Chaj.
Thank you so much, ma'am. Thank you, sir.
Ladies and gentlemen, now we will begin our cardiopulmonary resuscitation session. And to present this workshop, we have with us Mr. Rajkumar Jaiswal along with his team from Medanta Hospital, Gurugram. So please take over the stage and proceed with your CPR session.
It's just fine. No, it's just कोई कोई चाहिए तो I'll take the hand mic actually. हाँ सर. Is it getting change or something?
Sir, this can will help you to pinpoint the laser, and this will.
It's not working.
Sir, he will guide.
It's fine. It's done. Done. That's done. I'm just waiting for the mannequins. बैग नीचे रख दे. Mannequins ऐसे. I'll change it for. This one is for. Okay, it's fine. Okay, so good afternoon, everyone. Are you all sleeping? All are awake? Okay, so before starting, let me introduce myself. So my name is Rohan Sharma, and along with me, my team members, we belongs to Medanta Gurugram Hospital. Maybe आपने सबने सुना होगा Medanta Gurugram के बारे में. A little bit, right? So I used to work over there as a clinical instructor. So I'm not from pharma background. Okay, I used to work as a clinical instructor in Medanta. So we used to teach the doctors for BLS training, ACLS training, in-house training, and clinical areas trainings. Okay, so today we are here to represent a topic. Basically, this is something not going to be a lecture. Okay, so we will be more focusing on discussion. Okay, so we are going to represent the training that is basic life support. So in this training, we are going to discuss basic things. How do we are going to provide effective CPR to a cardiac arrest victim, and how do we are going to identify the victim is suffering from cardiac arrest, and how do we are going to activate the emergency response system as soon as possible so that we can increase the survival chance of the patient. Clear to everyone? If you are having any doubt, you can ask me in the between of session and the end of session as well. So we will demonstrate the high quality CPR, and some of selected members can perform chest compressions as well. ठीक है? तो अभी तक में भी थोड़ा बोरिंग लग रहा होगा आपको, अब प्रैक्टिकल वर्क आ गया है तो बी अवेक. Fine? Okay. So if we are discussing about BLS, so this BLS we have to give it to a cardiac arrest victim. Now the thing is कि आप cardiac arrest के patient को identify कैसे करोगे, है ना? So what can be a cardiac arrest? So I want to ask to you guys, what can be a cardiac arrest? Can anyone explain what can be a cardiac arrest? Yes, please. Anyone? Okay. So cardiac means heart. Okay. Arrest means when your heart is going to stop the pumping action. So that is the term is named as cardiac arrest. So अब वो cardiac arrest की condition आपके सामने कभी भी आपको देखने को मिल सकती है. जैसे कि हम सुबह से डिस्कस कर रहे हैं, there can be any kind of heart disease, heart attack, acute MI, CVD, coronary artery disease that can leads to cardiac arrest. और in many cases आपने देखा होगा कि रोड साइड एक्सीडेंट्स में भी क्या होता है, आपको कैजुअलिटी देखने को मिलती है, राइट?
तो आप उस टाइम पे एज सुन एज पॉसिबल यू विल एक्टिवेट द इमरजेंसी रिस्पॉन्स सिस्टम। आपको जल्दी से जल्दी रिकॉग्नाइज करना है विक्टिम को, यू आर द हेल्थ केयर प्रोवाइडर। और वन मोर थिंग कि हम जब इंडिया की बात करते हैं, इफ यू आर टॉकिंग अबाउट इंडिया एंड अमेरिका, देयर इज लॉट्स ऑफ डिफरेंस। ओके, तो यहाँ पर ज्यादातर लोगों को बीएलएस का मतलब ही नहीं पता होता है, फुल फॉर्म भी नहीं पता होता है। ओके, तो हेल्थ केयर प्रोवाइडर्स को एटलीस्ट बीएलएस तो आना ही चाहिए। और अमेरिका में क्या होता है कि एज पर द एएचए गाइडलाइंस सबको बीएलएस का कोर्स होना, सर्टिफाइड होना जरूरी होता है। सो आप समझो कि कितनी इंपॉर्टेंट ट्रेनिंग है ये। बेसिक सीपीआर, हाउ डू वी आर गोइंग टू यूज द एईडी, how do we are going to identify a cardiac arrest victim. Fine, so shall we start? Okay, so if we are talking about BLS, you must know about cardiac arrest. So there can be 3 signs and symptoms of cardiac arrest. Can you explain कि क्या क्या सिम्टम हो सकते हैं कार्डियक अरेस्ट के विक्टिम में? किसी को पता है? Chest pain. Okay, so this is the early signs of any heart disease, you can say chest pain. But once the victim becomes unresponsive, that is the sign of cardiac arrest. Cardiac arrest means अभी आपके हार्ट ने पंपिंग एक्शन को बंद कर दिया है. You have to restart that action by performing CPR. What is CPR? What is CPR? Cardiopulmonary and resuscitation. Basically, in this procedure, we are going to provide high quality CPR like this, and you are going to provide breathing. ठीक है, तो इसको हम बेसिक सीपीआर बोलते हैं। नाउ द थिंग इज कि आपको सीपीआर देना है कार्डियक अरेस्ट के विक्टिम को, आपको आइडेंटिफाई करना है बाय चेकिंग 3 थिंग्स। ओके, सो यू आर गोइंग टू रिपीट आफ्टर मी। सो व्हाट आर द 3 थिंग्स वी आर गोइंग टू चेक? ओके, सो फर्स्ट वन इज रिस्पॉन्स। रिस्पॉन्स इज बेसिकली यू आर गोइंग टू आस्क टू द विक्टिम कि वेदर विक्टिम इज एबल टू स्पीक, और विक्टिम आपकी बात का जवाब दे पा रहा है कि नहीं दे पा रहा है। सो दिस इज द थिंग, दिस इज द फर्स्ट थिंग यू हैव टू चेक। नेक्स्ट इज पल्स एंड ब्रीथिंग। व्हाट आर द 3 थिंग्स यू हैव टू चेक नाउ? Response, pulse, and breathing. So these 3 things we are going to check stepwise. So if you are talking about BLS, आपको BLS के steps follow करने हैं. So now there is a scenario for you. Okay, आप लोग कहीं आप MIT यूनिवर्सिटी के बाहर थे रोड साइड, and you just have seen कि एक victim कार चला रहा था जो कि has got a car accident and he collapsed on the steering wheel. So what is the first thing comes under your mind कि what are the things you have to perform over there? क्या करना चाहिए आपको वहां पर? चेक द रिस्पॉन्स। ओके, वुड यू बी एबल टू सर्वाइव और रिवाइव दैट विक्टिम इन द बिटवीन ऑफ द रोड? क्या आप उस विक्टिम को रोड के बीच में बचा पाओगे? नहीं, राइट? तो हो सकता है कि उसके साथ कार एक्सीडेंट हुआ है, तो आपके साथ भी हो सकता है ना? तो सबसे पहले क्या करना चाहिए आपको? यस प्लीज, साइड पे लेके जाओगे। सो बेसिकली what are you going to do is you are going to take the victim out of the car and you have to take the victim to the beside of the road and make him lie on a firm and flat surface, जैसे कि हमने मैनिक्विन को लगाया। firm and hard surface आपका होना चाहिए, ठीक है? so this is scene safety. You have to take care your safety as well as the patient safety as well. अभी सपोज करो एक और RTA हो गया है, रोड ट्रैफिक एक्सीडेंट, अभी आपको भी CPR की जरूरत पड़ गई, तो आप उसको बचाओगे, खुद को बचाओगे। so first step is scene safety. okay, scene safety आपने कर लिया। now the thing is you are going to check for the response. So how do we are going to check the response? Okay, pulse is different, response is different. Okay, response is basically we are going to ask to the victim कि आप बोल पा रहे हो, victim is conscious or not. Okay, consciousness level of the victim. So basically we are going to check it like this. I'll demonstrate. Okay, so you will ask like, sir, are you okay? Sir, are you okay? So this is how we are going to tap on the both of the shoulders in the same time, and we have to ask also. Fine. So you are going to tap on both of the shoulders in the same time, and you have to ask also. So this is the best method to check the response of the victim. आपको motor stimulus भी देना है और verbal stimulus भी देना है. So why both are the stimulus are important? दोनों stimulus देना आपको important क्यों है? अभी सपोज करो आप सिर्फ टैप करे जा रहे हो, ठीक है, और विक्टिम को क्या है, पैरालिसिया हुआ है। सो व्हाट विल हैपन? पेशेंट को सेंसेशन ही नहीं होगा। और अगर आप सिर्फ बोले जा रहे हो, आप टैप नहीं कर रहे हो, कि विक्टिम डिफ था, आपको पता चला बाद में, सो व्हाट विल हैपन? विक्टिम आपको जवाब नहीं दे पाएगा। सो दिस इज द थिंग, यू हैव टू चेक द रिस्पॉन्स बाय टैपिंग ऑन द बोथ ऑफ द शोल्डर्स इन अ सेम टाइम, एंड यू हैव टू आस्क ऑल्सो। क्लियर टू एवरीवन? So this is the early sign of cardiac arrest, that is unresponsiveness. So as soon as you have found कि victim is unresponsive, you have to shout for nearby help. आपको आसपास के लोगों को हेल्प चिल्लाना है, हेल्प के लिए बुलाना है। क्लियर टू एवरीवन?
क्या करना है आपको? व्हाट इज द फर्स्ट स्टेप? सीन सेफ्टी. आफ्टर दैट check for response. Third step, shout for help. Now we have to check for the pulse and breathing. Okay, अभी मैं आपको आगे बताऊंगा कि हेल्प के लिए चलाना क्यों जरूरी है. फाइन. सो नाउ वी हैव टू चेक फॉर द पल्स एंड ब्रीथिंग. सो इन केस ऑफ नॉर्मल पेशेंट्स आपने देखा होगा मे बी डॉक्टर्स कौन सी पल्स चेक करते हैं? रेडियल. बेसिकली रेडियल पल्स चेक करते हैं. ओके, बट इन केस ऑफ कार्डियक अरेस्ट आपको चेक करना है कैरोटिड पल्स. वेयर कैन यू लोकेट द कैरोटिड पल्स एवरीवन? In the neck region basically. Okay, so everyone is going to locate the pulse with me. So everyone take your fingers like this, 2 or 3 fingers, place your fingers to the tracheal region and then slide your fingers to the groove area. Basically जहां पर आपको ये गड्ढा सा दिखाई दे रहा है, यहां पर आपकी कैरोटिड पल्स है. Are you able to locate the pulse? कोई ऐसा तो नहीं है कहते मेरे पास पल्स नहीं है? Everyone is having pulse, right? सो अलोंग विद द पल्स आपको ब्रीथिंग भी देखना है. ब्रीथिंग कैसे पता चलेगा आपको विक्टिम इज ब्रीथिंग और नॉट? ओके, अगेन एवरीवन, देयर इज कंफ्यूजन इन चेकिंग द पल्स. एवरीवन प्लीज लोकेट द ट्रैकिया एंड किसी भी साइड, इधर टू एनी साइड यू कैन ड्रैग योर फिंगर्स टू द ग्रूव एरिया. अगर किसी को फील नहीं हुआ है दैट कैन कम ऑन द स्टेज, मैं उसको मेरी पल्स फील करके दिखाऊंगा. एवरीवन इज एबल टू लोकेट द पल्स? ओके, so along with the pulse you have to check the breathing as well. अभी breathing कैसे चेक करोगे आप? पूछोगे विक्टिम को सांस ले रहे हो? सो कैसे चेक करोगे? ओके, नोस्ट्रिल से सुन सकते हो. बेसिकली आपको एक साउंड सुनाई देगा, बट एज पर द AHA गाइडलाइंस बेस्ट मेथड टू चेक द ब्रीथिंग, बेस्ट मेथड टू कंफर्म द ब्रीथिंग इज जस्ट ऑब्जर्व द चेस्ट राइज. ओके, सब लोग एक बार गहरी सांस लो. ओके, छोड़ दो. सो अभी क्या हुआ है? बायलेटरल चेस्ट राइज हुआ है, राइट? तो उस टाइम पे भी विक्टिम को आपको क्या देखना है? चेस्ट राइज. सो दिस इज हाउ वी आर गोइंग टू चेक. रिस्पॉन्स चेक किया, शाउट फॉर हेल्प विद योर नियरेस्ट हैंड, नियरेस्ट पल्स यू आर गोइंग टू चेक एंड यू जस्ट हैव टू ऑब्जर्व द चेस्ट फॉर द चेस्ट मूवमेंट. फाइन. अभी आपको कितनी देर के लिए चेक करना है पता है किसी को? कितनी देर के लिए चेक करोगे आप ऐसे? 1 मिनट. ओके, सो अगर आप पल्स की इंटेंसिटी असेस कर रहे हो या फिर आप पल्स रेट असेस कर रहे हो, उस टाइम पे आप 1 मिनट के लिए करते हो. फाइन. सो इन केस ऑफ कार्डियक अरेस्ट विक्टिम आप 10 सेकंड से ज्यादा टाइम वेस्ट किसी चीज में नहीं करोगे. सो यू आर गोइंग टू चेक द पल्स विद इन 10 सेकंड्स. इन हाउ मच टाइम? विद इन 10 सेकंड्स. ओके, सो यू हैव टू प्लेस योर फिंगर्स, आई शुड बी ऑन द चेस्ट, काउंट फॉर 10 सेकंड. सो सपोज यू हैवंट गॉट एनी पल्स एंड ब्रीथिंग. अभी आपको क्या कंफर्म हो गया? विक्टिम किस कंडीशन में है? कार्डियक. एवरीवन, कौन सी कंडीशन में है विक्टिम? फीवर तो नहीं हुआ है? कार्डियक अरेस्ट, राइट? सो बेसिकली आपका हार्ट ने पंपिंग एक्शन बंद कर दिया है. नाउ यू हैव टू रीस्टार्ट बाय परफॉर्मिंग चेस्ट कंप्रेशंस, जिसको हम क्या बोलते हैं? CPR. और इन केस ऑफ अनकॉन्शियस विक्टिम और वी कैन से इन केस ऑफ BLS वी आर फॉलोइंग दिस सीक्वेंस: कंप्रेशन फर्स्ट, एयरवे एंड ब्रीथिंग सीक्वेंस. व्हाट इज द सीक्वेंस? कंप्रेशन, एयरवे एंड ब्रीथिंग सीक्वेंस. सो इसमें आप क्या करोगे? कार्डियक कंप्रेशंस, ओके, एयरवे मेंटेन करोगे एंड देन यू आर गोइंग टू प्रोवाइड ब्रीथिंग. ब्रीथिंग कैसे देते हो आप लोग पता है आपको? माउथ टू माउथ, और इधर यू आर हैविंग एनी काइंड ऑफ बैरियर डिवाइसेस, देन आल्सो यू कैन डिलीवर द ब्रीथ. ठीक है. सो द थिंग इज, पहले आपको जैसे ही आपको आइडेंटिफिकेशन हो गया विक्टिम इज इन कार्डियक अरेस्ट, यू हैव टू कॉल द कार्डियक एम्बुलेंस. इज देयर एनी इमरजेंसी रिस्पांस सिस्टम in our MIT university? Is there any emergency response system? Yes. What is the number, sir, please? Is there any particular number for EMS? Okay, you just have to call the ambulance then. Okay, so you are going to call the ambulance as soon as you have recognized victim is in cardiac arrest and you will start the CPR. इसलिए हेल्प के लिए बुलाना जरूरी है कि जो अनदर पर्सन आपकी हेल्प के लिए आएगा, दैट पर्सन इज गोइंग टू कॉल द कार्डियक एम्बुलेंस और आप इतने क्या करोगे? CPR. ठीक है. So I'll demonstrate once कि how do we are going to provide the chest compressions. So for starting chest compression, आपको आपके हाथ कहाँ रखने हैं? किसी ने किए कंप्रेशन या फिर किसी को करते हुए देखा है? नहीं देखा है. ओके, किसी ने देखा है तो प्लीज रेज योर हैंड. फाइन, तो सबको सीखना चाहिए. ओके, किसी को नींद नहीं आनी चाहिए. सो द थिंग इज यू हैव टू प्लेस हील ऑफ योर डोमिनेट हैंड इन द सेंटर ऑफ द चेस्ट. फर्स्ट थिंग, सेंटर में रखना है आपको, लेफ्ट राइट नहीं रखोगे. Okay, and you have to place your hand in the lower half of the sternum bone. So this is basically the sternum bone. You have to place heel of your dominant hand in the lower part of the sternum bone. So this is the proper position, or we can say the side to perform the compressions. Okay, and then you have to interlock it with another hand. आपको इसको दूसरे हाथ से क्या करना है? Interlock. And then I will demonstrate कि आपको कैसे करना है. Fine. So one more thing is there. अगर आपको ऐसे सरफेस पे आपने विक्टिम को लेटाया है कि आप कंप्रेशन नहीं कर पा रहे हो, सो बेस्ट मेथड इज कि आप विक्टिम को फ्लोर पे ले लो. ठीक है, क्योंकि उस टाइम पे टाइम वेस्ट नहीं करना है. I'll demonstrate on table once and then you can perform anywhere. ऐसा कोई जरूरी नहीं है आप फ्लोर पे नहीं कर सकते, बल्कि AHA बोलता है फ्लोर पे कंप्रेशन सबसे आसान होते हैं. फाइन. This is how we are going to perform the compression. This much speed you have to maintain, this much depth we have to maintain. Okay. Your elbow should be always straight.
Can I keep it in?
Am I audible to everyone? Am I audible? Okay, so this is how basically we are going to perform the compression. So while performing compression, your elbow should be always straight. It should not be bent with the compression. Okay, and then you have to lean forward on the victim. So lean forward is basically your shoulder should directly come over the victim chest so that you can compress downside. अगर आप ऐसे compression करते हो, you will just push the victim back. और आप heart को compress नहीं कर पाओगे. So that's why we are named these compressions as cardiac compressions as well. Fine. So आपको क्या करना है? पहले compression करोगे, उसके बाद आपको कौन सा sequence maintain करना है? Airway and breathing. तो पहले compression को discuss कर लेते हैं कि effective compression होते क्या है. So this is basically basic things जो आपको parameters याद होने ही चाहिए, right? So what is the rate of compression? पता है आपको किसी को कि compression की speed कितनी होनी चाहिए? बेसिक चीजें ये आपको पता होनी चाहिए. That is 100 to 120 compressions per minute. Basically आप ऐसे सिली सा एग्जांपल देता हूं आपको. आप गाड़ी चला रहे हो 100 to 120 की स्पीड पे, ओके, और आपको उस गाड़ी में ब्रेक लगाना है 30 कंप्रेशन के बाद, लेकिन आपकी स्पीड कितनी होनी चाहिए? 100 to 120. फाइन. सो दीज आर द पैरामीटर्स ऑफ हाई क्वालिटी CPR. So it will not be visible, we will discuss. Okay, so आपको एक बारी में कितने कंप्रेशन करने हैं? 30 कंप्रेशन एंड 2 ब्रीथिंग. कितने कंप्रेशन करोगे आप? 30 कंप्रेशन एंड 2 ब्रीथिंग. और स्पीड आपकी कितनी होनी चाहिए? दैट इज योर 100 to 120 कंप्रेशन पर मिनट. फाइन. और आपकी डेप्थ ऑफ कंप्रेशन होनी चाहिए, दैट इज एटलीस्ट 2 इंचेस एंड 5 सेंटीमीटर. कितना होना चाहिए? एटलीस्ट 2 इंचेस एंड 5 सेंटीमीटर. और whenever you are going to compress the chest, you have to allow the complete chest recoil. Okay, so chest recoil is basically जब जितना भी आप chest को compress कर रहे हो, सपोज करो आपने 2.2 इंच तक कंप्रेस किया. ओके, सो यू हैव टू अलाउ द कंप्लीट चेस्ट टू कम बैक टू इट्स नॉर्मल पोजीशन अगेन. उसको हम क्या बोलते हैं? चेस्ट रिकॉइल. सो चेस्ट रिकॉइल इज वेरी इंपॉर्टेंट व्हाइल परफॉर्मिंग कंप्रेशंस. सो एट मीनवाइल टाइम व्हाट विल हैपन इज इफ यू आर गोइंग टू कंप्रेस द हार्ट, ओके, so blood will go out of the heart. If you are not allowing proper chest recoil, there will be no refilling of the blood into the heart, and in the result decrease cardiac output. Basically we have to maintain the chest recoil whenever we are going to provide the effective compressions. Okay, are the parameters are clear? All the parameters are clear? Yes, sir. Okay, so here is a scenario, we will discuss by the scenario. Okay, so there is a worker, हमारे गार्ड साहब है, and they have seen कि victim is collapsed from the chair. So what is the first thing we have to do over here? क्या करोगे आप? पहले check the response? No. Basically आप चेयर को दूर करोगे, okay, surrounding area को सेव करोगे, and you are going to turn the victim to the spine position. Fine. Basically first step is scene safety. Make the person lie on a firm and flat surface. Next is check for the response by tapping on the shoulder, and we have to ask also. Next, if response is not there, then shout for nearby help. Next is check the carotid pulse and breathing for how many seconds? Less than 10 seconds, 5 to 10 seconds basically we can say. Okay, so basically this number is belongs to Medanta, आप लोग मत डायल कर देना, ठीक है? So this is basically a code blue number. अगर आप किसी clinical areas में आके काम करते हो, so you may be able to see कि we are going to announce code blue if the victim is in cardiac arrest. So वहां पर एक advance team आती है victim को revive करने के लिए, but you just have to remember कि you have to activate the particular area's emergency response system. So you will call the cardiac ambulance over here. Okay, and then you will start high quality CPR. So where are we going to place our hand for the compression? In the between of the chest, in the center of the chest, in the lower part of the sternum bone. Clear to everyone? Yes or not? Okay, so next is, what is the ratio of compression? 30 compression and 2 breathing we will discuss. Okay, so next is, you can give mouth to mouth breathing, or maybe you will be having some barrier devices. Okay, so this is ambu bag we are using in hospital scenarios, but outside of hospital scenario you can use this one. So this is pocket mask, we'll discuss one by one. Okay, so next is your rate of compression. Rate of compression कितना होगा आपका? 100 to 120 compressions per minute. So this is the thing. Okay, so now comes to the sequence. So this is the sequence we were maintaining. अभी तक आपने क्या perform कर दिया? Compression. Now we have to maintain the airway. So basically airway we are going to maintain by performing head till chin lift. Okay, basically if you are going to go for the mouth to mouth breathing, so first you have to pinch the victim's nose. Clear to everyone? First we are going to pinch the victim nose, and we have to hyperextend the neck and open the chin a little bit, and you have to deliver the breath by contacting the patient's mouth with our mouth properly. Okay, सबको समझ में आया? So this is how we are going to deliver the breath. I'll demonstrate. 1, 2. So this is how we are going to deliver the breath, and you have to deliver one breath for 1 second. You have to wait for 1 second, and then another breath for another 1 second. So ये अभी आपने कौन सा sequence follow किया? Compression, airway maintenance by performing head till chin lift, and then you have to deliver the breath. Clear to everyone? Okay. So next is pocket mask. So this device we can say कि आपने नहीं देखा होगा कभी. देखा कभी ऐसा device? देखा है? Okay. So usually this device will be available airport. Okay. So airport पे होता है, कई बारी आपका first aid kit में होता है. Okay. So जिसको certified AHA training मिली होती है, so वो लोग इसको रख सकते हैं. Those who are working in EMS team, emergency response team में जो काम कर रहे हैं वो रखते हैं इसको. Okay. So अभी आपको एक बात का ध्यान रखना है कि कुछ लोग बोलेंगे कि हमने इसको आज तक देखा नहीं तो आगे क्या यूज करने को मिलेगा, right? So first aid care is all about to use the equipments. जब भी आपको देखने को मिले, you have to use it. Okay? तो इसलिए आपको पता होना चाहिए कि हाँ ये डिवाइस काम कैसे करते हैं. So basically this narrow part you have to place over the nose bridge. इसमें क्या फायदा होगा? आप डायरेक्ट माउथ टू माउथ कॉन्टैक्ट को अवॉइड कर सकते हो. So this narrow part you have to place over the nose bridge, and this broader part you have to place over the chin area. And then same, you have to seal the mask properly so that there should be no leakage. Perform head till chin lift and deliver the breath. How many breaths you will give? 2 breaths. One breath for 1 second, wait for 1 second, another breath for another 1 second. One thing also you can do is you will deliver the breath and you will observe the chest rise. Okay, अगर आपकी breath के साथ chest rise हो रहा है, it means your breaths are effective. Okay, so this is how we are going to deliver. 1, 2, and observe the chest rise as well. So it will give you the feedback whether your breaths are effective or not. अगर मान लो आपको chest rise दिखाई नहीं दिया, तो क्या feedback मिलता है आपको? It means आपके breaths effective नहीं है. So what you will do? So there can be two situations. Okay, या तो आपने head till chin lift अच्छे से नहीं किया, आपका airway block है. You have to open the airway. Okay, and हो सकता है कि आपने mask बहुत ज़्यादा नीचे लगा दिया हो और वहाँ से air leak हो रहा हो. Okay, so if we are providing mouth to mouth breath, that will deliver around 16 to 70% of oxygen. And if we are using pocket mask, it will deliver around 40% of oxygen. So that's why these barrier devices are most important thing while providing BLS, basic life support. Clear to everyone? Okay. Now the thing is there any doubt till now? Fresh में ही doubts clear कर लेते हैं. Any doubts? Okay. तो yes, please. Okay. So what you can do is, if there is any bleeding, sometime vomiting can also be there, right? हो सकता है कि आप comfortable भी ना हो, opposite gender भी हो, है ना? So what you will do is you will do is you are just going to clean the area. अगर आप comfortable हो mouth to mouth breathing देने में, then go for it. अगर आपको लग रहा है कि no, I'm not comfortable with this thing, you will just skip the breathing part, you will just continue the chest compression. तो उसको हम बोलते हैं CCC, continue chest compressions. Okay, yes please. Okay, so in case of adult patient, आप compress कर सकते हो 1/3 of the chest. अगर आपको 2 इंचेस और 5 सेंटीमीटर के पैरामीटर्स याद नहीं रहते हैं, देयर इज नो फीडबैक डिवाइस आउटसाइड ऑफ हॉस्पिटल. हॉस्पिटल के अंदर वी आर हैविंग ए फीडबैक डिवाइस कि आपको इतना ही कंप्रेस करना है, बट आउटसाइड आप ऐसे ही कंप्रेस करते रहोगे, हो सकता है कि बोन ब्रेकेज भी हो जाए. ओके, रिब्स फ्रैक्चर भी हो सकता है, बट यू विल कंटिन्यू द सीपीआर इन दैट कंडीशन आल्सो एज पर द AHA गाइडलाइंस. Okay, that can harm the patient. Once the patient revived, we will heal the bones, right? So this is the thing. Any more doubts until now? Yes please. Who's asking? Okay, please, sorry. What is the difference between heart attack and? Okay, so it depends upon the patient condition. Basically, you will activate the emergency response system as soon as possible. Or heart attack can be defined by some sign and symptoms like sweating, radiating chest pain, or chronic chest pain, unstable angina we can say. So in this condition, पहले तो आपको emergency response system activate करना है, और as soon as possible आपको किसी डॉक्टर से तो आपको कंसल्ट लेना है. Okay, basically in unstable angina we are prescribing कि आप as soon as possible aspirin दे दो, right? But आपको एक बार आपके physician से एक बार पूछ लेना, ठीक है? So this is the thing. Any more doubts? Okay, so next is in case of cardiac arrest we have to deliver the shock as well. तो आप कुछ कंडीशन में शॉक भी देते हो. किसी ने फिल्मों में शॉक देते देखा है? Yes or no? Okay, तो कार्डियक अरेस्ट के केस में शॉक देते हैं. कुछ डिफरेंट कंडीशन भी होती है जिसमें हम शॉक देते हैं, बट वो कंडीशन हम डिस्कस नहीं करेंगे, लेकिन हम कार्डियक अरेस्ट जरूर डिस्कस करेंगे. फाइन. सो वी विल बी हैविंग ए डिवाइस फॉर डिलीवर द शॉक, जिसको हम बोलते हैं AED. दैट इज योर ऑटोमेटेड एक्सटर्नल डिफिब्रिलेटर. So this device we are using outside of hospital scenarios. और सेम जैसे कि आपकी फर्स्ट एड किट है, EMS सिस्टम है, एयरपोर्ट्स है, रेलवेज है, वहां पर आपको ये देखने को मिल सकता है. इट कैन बी डिफरेंट इन शेप बट द यूज इज सेम ओनली. सबका यूज सेम है, ठीक है? सो दिस इज ए ऑटोमेटिक डिवाइस. इट विल गिव यू द इंस्ट्रक्शंस. यू आर जस्ट गोइंग टू फॉलो द इंस्ट्रक्शंस ऑफ द AED. सो आपको इसको यूज करने के तो सिर्फ 2 सिंपल स्टेप है. फर्स्ट आपको इसको ऑन करना है बाय प्रेसिंग दिस ग्रीन बटन, एंड आपको इसके इंस्ट्रक्शंस को फॉलो करना है. So like this it will work. Okay, I'll demonstrate.
Apply pad to patient's bare chest. Plug in pad's connector next to flashing light.
Okay, क्या बोल रहा है ये? सुनाई नहीं दिया, राइट? एक बार दोबारा से सुनते हैं, ठीक है? ध्यान से सुनना प्लीज.
Apply pad to patient's bare chest.
क्या बोला? Apply pads to the victim's bare chest. Okay. Now the thing is you are going to expose the victim first and you are going to apply the pads now. Okay. The thing is कि आपको pad placement भी नहीं पता होगा कि लगाना कहाँ है, right? So you are going to apply the pads. अभी आपको याद कर लेना है. Right side you will apply the pad just below the collarbone. So ये आपकी collarbone है, and just below the collarbone you will apply this pad. अब यहाँ पर कोई left right नहीं होता है AED में, आप कोई pad कहीं भी लगा सकते हो, ठीक है? आपने यहाँ पे लगाया एक pad. Okay, I'll demonstrate once. एक पैड आपने यहाँ पे लगा दिया, एंड द अनदर पैड यू हैव टू अप्लाई जस्ट बिलो द निपल लाइन. और अगर आप प्लेसमेंट भूल भी जाते हो, सो देयर इज अ मार्किंग, यू कैन फॉलो द मार्किंग एज वेल. यहाँ पर AED के पैड्स के ऊपर एक मार्किंग होता है, ठीक है? आपको थोड़ा बहुत दिख भी रहा होगा. देयर इज अ मार्किंग, यू कैन फॉलो द मार्किंग. सो सपोज अभी आपने पैड्स लगा दिए. ओके, नाउ यू हैव टू प्लग इन द कनेक्टर. जैसे कि आप ECG लेते हो विक्टिम का, ठीक है?
Analyzing heart rhythm.
So it is analyzing the heart rhythm. सबको समझ में आ रहा है? It is analyzing the heart rhythm कि whether the rhythm is shockable or non-shockable. So in case of cardiac arrest, there can be only 2 types of rhythms: shockable or non-shockable. So shockable rhythms are 2 only, that is pulseless ventricular tachycardia and ventricular fibrillation. So in case of non-shockable rhythms, there are also 2 rhythms, that is asystole and pulseless electrical activity. तो आपको इतना सब याद करने की जरूरत नहीं है. You just has to follow the AED instructions. AED जो आपको इंस्ट्रक्शन देगा, शॉक देने को बोलेगा, you have to deliver the shock. अगर आपको बोला there is no shock advice, you are not going to deliver the shock, you will continue with the chest compression. Okay, let's see हमारा AED हमको क्या बोल रहा है.
Do not touch the patient.
क्या बोला? Do not touch the patient. Why? So it is analyzing heart rhythm and saying कि do not touch the patient. Why? शॉक लगेगा नहीं, अभी तो सिर्फ एनालाइज कर रहे हैं हार्ट रिदम को, देख रहे हैं कि वेदर द रिदम इज शॉकेबल और नॉन शॉकेबल। एक बार सर ने भी बताया था कि कई बार पेशेंट को टच करने से कुछ फिब्रिलेटिंग एक्टिविटी आ जाती है और पता चलता है कि पेशेंट को आर्टेरियल फिब्रिलेशन था। वो एक घूमने वाला एग्जांपल भी दिया था कि पता चला वो लड़की था, याद आया? सो दिस थिंग कैन आल्सो बी हैपन। अगर आप बाहर से पेशेंट को टच कर रहे हो ड्यूरिंग एनालाइजिंग द हार्ट रिदम, देयर कैन बी सम इरेगुलर एक्टिविटी बाय योर टचिंग। So that's why we are not going to touch the victim whenever we are going to analyze the heart rhythm. ECG लेते हुए भी पेशेंट को टच नहीं करते हैं। So this is the thing। अभी आपको क्या बोलना है? All clear। जब भी AED एनालाइज कर रहा है हार्ट रिदम को, आप क्या बोलोगे? All clear। ओके? सपोज आपने all clear बोला, सब लोग पीछे हट जाएंगे। क्या बोला? Shock advised। Charging। So at this meantime you will continue with the chest compression. We are not going to waste the time. So it will take around 15 to 20 seconds for deliver the shock. So maximum joules is 200। ये 200 पे सेट होता है। In case of cardiac arrest victim आप 120 to 200 joules shock दे सकते हो, ठीक है? बट ये maximum joules पे सेलेक्ट होता है तो आपको maximum ही देना है। So we will continue with the chest compression। दोबारा से क्या बोला? Stay clear from the patient and deliver the shock। सबको सुनाई दिया? डिलीवर शॉक नाउ एंड प्रेस दिस ऑरेंज बटन नाउ। अभी आपको शॉक देना है। अभी आपको क्या ध्यान रखना है? कोई टच कर सकता है विक्टिम को? नहीं। दिस टाइम वी हैव टू से अगेन ऑल क्लियर। अब की बार आप दोबारा से क्या बोलोगे? ऑल क्लियर बोलोगे आप एंड यू विल डिलीवर द शॉक बाय प्रेसिंग दिस ऑरेंज बटन। शॉक डिलीवर्ड एंड अगेन बिगिन सीपीआर। ओके? सो अगर आपने एक बार एडी लगा दिया है, so you will just continue with by using this। okay? आप इसको ऑफ नहीं करोगे, आप पैड्स नहीं हटाओगे, आप पैड्स के ऊपर से ही कंप्रेशन करोगे, क्योंकि 2 मिनट के बाद आपको ये दोबारा से इंस्ट्रक्शन देना शुरू करेगा whether the rhythm is shockable or non shockable। so you will just again going to follow the instructions of the AED। सबको क्लियर हुआ? okay, why we are delivering shock? what is the action of shock in our body? what is the basically action of shock in our body? पता है किसी को? okay, so there are arrhythmias that is causing the cardiac arrest। मैंने कौन सी 2 रिदम बताई शॉकेबल? कोई बता सकता है? pulseless ventricular tachycardia and ventricular fibrillation। okay, so इनमें क्या होता है कि in case of ventricular fibrillation your heart is just vibrating, वहां पर कोई एक्टिविटी नहीं रहती है for circulation। so आपको उस abnormal एक्टिविटी को कुछ टाइम के लिए स्टन करना पड़ेगा, रोकना पड़ेगा। that's why we are delivering the shock। ओके, सो आपका शॉक क्या काम करेगा? वो स्टन कर देगा हार्ट को, और जब आप दोबारा से कंप्रेशन करोगे इट विल रेगुलरली स्टार्ट टू पंप द ब्लड मे बी। ठीक है? सो बेसिकली शॉक हैज 2 एक्शंस। फर्स्ट इज वी आर गोइंग टू डिलीवर द शॉक टू एलिमिनेट द एब्नॉर्मल हार्ट रिदम एंड टू रिस्टोर द नॉर्मल हार्ट रिदम। सबको क्लियर हुआ? what are the 2 actions of shock? first to eliminate the abnormal heart rhythm, second is to restore the normal heart rhythm। so this is the thing, we have to use the AED as soon as possible, we have to activate the emergency response system as soon as possible। अभी तक किसी ने एक क्वेश्चन नहीं पूछा कि आप कितनी देर तक सीपीआर करते रहोगे? कितनी देर तक करते रहोगे आप? जब तक रिस्पॉन्स नहीं आ जाता। ओके, सो आफ्टर रिवाइवल, उसको हम बोलते हैं ROSC, रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन। ओके, सो अगर विक्टिम रिवाइव भी हो जाता है तो एकदम से रिस्पॉन्स नहीं आएगा, विक्टिम विल नॉट बी एबल टू स्पीक इन मेनी सिनेरियोस। सो व्हाट यू हैव टू डू इज यू हैव टू चेक द पल्स अगेन। अभी आपको पल्स कब चेक करना है? आफ्टर एवरी कंप्लीशन ऑफ 2 मिनट्स और 5 साइकिल्स। आपको 30 कंप्रेशन के 5 साइकिल हो गए हैं, या फिर यू हैव कंप्लीटेड 2 मिनट्स ऑफ कार्डियक कंप्रेशंस, then also you can go for the checking pulse and breathing। अगर पल्स आ गए हैं तो क्या करना है आपको? It means patient is revived, right? तो क्या करोगे आप? छोड़ दोगे उसको वहीं पे? So what you will do? Yes sir, किसने बोला? So you will shift the patient to the particular area, और अगर पल्स नहीं आया है तो क्या करना है आपको? You will continue the CPR for another 2 minutes। हो सकता है कि 2 मिनट के बाद पेशेंट रिवाइव ना हो, उससे नेक्स्ट 2 मिनट्स या फिर उससे नेक्स्ट 2 मिनट के बाद हो जाए, बट यू विल जस्ट पुश ब्लाइंडली जब तक आपकी एम्बुलेंस नहीं आ जाती है। क्लियर टू एवरीवन? यस और नॉट? ओके, सो नेक्स्ट इज इन्फेंट। सो इन्फेंट ग्रुप क्राइटेरिया इज 0 to 1 ईयर। अभी तक हम डिस्कस कर रहे थे अडल्ट पेशेंट के बारे में। ओके, सो इन्फेंट में क्या होता है कि हार्ट डिजीज बहुत ज्यादा रेयर होती है। आपने सुना है कभी किसी को इन्फेंट में कार्डिक सॉरी आपको हार्ट ब्लॉक हो गया या फिर हार्ट अटैक आ गया, सुना है किसी ने? इट्स वेरी रेयर। ओके, सो इन केस ऑफ इन्फेंट व्हाट विल हैपन इज पल्मोनरी सिस्टम में डिफेक्ट होते हैं एंड दैट लीड्स टू कार्डियक अरेस्ट। ओके, so the thing is you have to identify the risk of cardiac arrest in case of infant and you have to just revive the victim. So basically what is the first step of BLS? What is the first step? Scene safety. Okay, and the next step is check for the response. Adult में कैसे कर रहे थे आप check response? Tapping on the shoulders along with the verbal stimulus. Infant में कैसे करना है आपको? Infant में कैसे करोगे? Pinch करोगे? कहाँ पे? Okay, so the thing is now you have to tap on the sole of the feet. Okay, so most sensitive area is sole of the feet. You have to tap on the sole of the feet along with the verbal stimulus. So suppose Nushant hai. Okay, Nushant, are you okay? कोई Nushant तो नहीं है ना? Okay, so this is how we are going to check the response and then you have to shout for nearby help अगर response नहीं मिलता है तो as soon as possible. And then you have to check the pulse and breathing. अभी adult patient में कौन सी pulse check कर रहे थे आप? Carotid pulse. Where can you locate the carotid pulse? In the neck region basically. किस side? Left side या right side? Both side. Okay, so both side. But आप कौन सी चेक करोगे? The nearest one, जो आपके पास में है. Okay, अभी infant में कौन सी pulse चेक करोगे आप? We are discussing about less than 1 year. Okay, कौन सी pulse चेक करोगे? Carotid करोगे? Okay, so this time we will go for a brachial pulse. अभी आपको कौन सी pulse चेक करनी है? Brachial pulse. अभी brachial pulse, अभी BP किसने चेक करवाया? BP. कहाँ करवाते हो आप BP चेक? So इसको बोलते हैं antecubital fossa. Okay, so antecubital fossa में you can locate your carotid pulse, but infant की अलग होती है। infant में आपको locate करनी है shoulder और elbow के बीच में अंदर की साइड, यहाँ पर। Always use your fingers to check the pulse, never use your thumb. Okay, thumb में इसकी खुद की एक pulse होती है। So this is how we are going to check the pulse and breathing. Breathing कैसे check करोगे आप? You will observe the chest movement. कितनी सेकंड के लिए चेक करना है आपको pulse and breathing? ये बार बार हम इसलिए रिपीट कर रहे हैं सो दैट आपको याद रहे। ओके, कितनी सेकंड के लिए? 5 to 10 सेकंड के। ओके, सपोज करो देयर इज नो पल्स नो ब्रीथिंग, अभी क्या करना चाहिए आपको? सपोज देयर इज नो रिस्पांस, नो पल्स, नो ब्रीथिंग, नाउ व्हाट यू विल डू? यू विल स्टार्ट CPR और फर्स्ट थिंग इज एक्टिवेट इमरजेंसी रिस्पांस सिस्टम। ठीक है, फर्स्ट थिंग इज एक्टिवेट द इमरजेंसी रिस्पांस सिस्टम एंड देन स्टार्ट CPR। अभी आपको कार्डियक अरेस्ट की वेट नहीं करना है। अगर किसी के घर में लेस देन 1 ईयर का कोई बच्चा है तो एक बार पल्स चेक करके देखना। ठीक है, सो दिस इज द थिंग। अभी बच्चों में कंप्रेशन करने कैसे हैं? क्या आप दोनों हाथों से कर सकते हो? अभी किसी ने बोला था कि टूट जाएगा, है ना? यहाँ पर हो सकता है। सो अभी आपको क्या करना है? अभी आपको 2 मेथड यूज कर सकते हो आप लोग। सो जो आपको राइट साइड में दिख रहा है, एक ये मेथड होता है हमारा, दैट इज टू फिंगर टेक्निक। ओके, एंड द अनदर वन इज थंब एनसर्कलिंग टेक्निक। सो दिस इज बेसिकली अनदर मेथड टू रिलीव द चोकिंग, बट CPR में भी आप इसी मेथड को यूज करते हो। सो 2 फिंगर टेक्निक आपको कहां रखना है? यहां पर आप हाथ कहां रख रहे थे? सेंटर ऑफ द चेस्ट। यहां पर भी आपको सेंटर में रखना है। और पर्टिकुलर एरिया पे कहां पे रख रहे थे? sternum bone पे, राइट? So in case of infant, you will not be able to easily locate the sternum bone. तो आपको क्या करना है? You are just going to place your fingers just below the nipple line. जैसे आपको बच्चे की nipple line दिख रहा है, उससे नीचे आप क्या करोगे? आपकी fingers को रख दोगे, and you will start the compression. Okay, 1, 2, 3, 4. So this is how we are going to start the compressions. और दूसरी टेक्निक के लिए you are going to hold the infant from the edges. आपको सेम आपके 2 thumb encircling टेक्निक यूज करना है, एंड आपको कंप्रेशन स्टार्ट कर देना है ऐसे ही सेम 1, 2, 3। 1 मिनट में कितनी कंप्रेशन करोगे आप? 30, 100 to 120 compressions per minute. 30:2 is your ratio. We have to maintain 30:2. Now there is a slightly change in infant. Okay, if we are working alone or you are single rescuer, then you will go for 30:2. If you are working in a team, then you have to deliver 15 compression and 2 breathing. How many compression? 15. 15 compression and 2 breathings. So this is the thing we have to maintain. अभी इसके पीछे भी एक anatomical reason है. Okay, so यहाँ पर क्या कॉज बताया था कार्डियक अरेस्ट का? रेस्पिरेटरी अरेस्ट. रेस्पिरेटरी अरेस्ट इज द मोस्ट कॉमन कॉज इन केस ऑफ इन्फेंट पेशेंट. इसलिए आपको ब्रीथिंग पार्ट पे ज्यादा फोकस करना है. और ब्रीथिंग पे आप कब फोकस कर सकते हो? व्हेन यू आर मोर देन वन रेस्क्यूअर और यू आर वर्किंग इन ए टीम. सो इसलिए बोलते हैं कि इन्फेंट में आप 15 के बाद यू कैन एक्सीड मोर देन 2 ब्रीथिंग आल्सो. ओके, यू कैन एक्सीड मोर देन 2 ब्रीथिंग आल्सो. और आप कितनी देर के लिए कंप्रेशन करते रहोगे? एटलीस्ट फॉर 2 मिनट्स. 2 मिनट्स के बाद आपको क्या करना है? फिर से सीपीआर तब स्टार्ट करना है अगर पल्स नहीं है तो. सो फर्स्ट यू विल असेस द पल्स एंड ब्रीथिंग अगेन. क्लियर टू एवरीवन? ओके. कैन वी डिलीवर शॉक इन इन्फेंट? शॉक दे सकते हैं इन्फेंट में? यस, वी कैन डिलीवर द शॉक. ओके, सो सेम रिदम्स विल बी देयर. वही रिदम है जो इन्फेंट में भी कार्डियक अरेस्ट कॉज कर रही है, वही रिदम है जो कि आपको अडल्ट में भी देखने को मिलेगी. So now the thing is, pads may be different. Okay, so these are your adult pads, these are your pediatric or infant pads. Okay, so now the thing is, where are we going to place the pads? Okay, so one pad you have to place over the center of the chest, anterior of the chest and posterior of the back. अभी आप शॉक दे सकते हो सेम मेथड से जैसे कि आप अडल्ट में दे रहे थे. सबको क्लियर हुआ? Is there any doubt? Okay. So while handling AED, अभी आपको लग रहा होगा कि एक बार डेमोन्स्ट्रेट होने से या फिर एक बार ट्रेनिंग हो जाने से we will not be expert to deliver the shock, right? So आपको कुछ स्पेशल कंसिडरेशंस का भी ध्यान रखना है. Like there can be some special patients कि उन पे आप AED कैसे यूज करोगे और शॉक देते हुए क्या क्या चीजों का ध्यान रखना है. Okay, so suppose patient was drowning, कोई डूब रहा था, तो उस टाइम पे आप क्या करोगे? Can anyone tell? कि कोई डूब रहा था और आपको उस विक्टिम पे सीपीआर स्टार्ट करना है और आपको उसी विक्टिम पे एईडी भी यूज करना है. कैसे करोगे? यू विल टेक द विक्टिम आउट ऑफ द वाटर फर्स्ट. ठीक है, सेम चीजें परफॉर्म करोगे. रिकॉग्नाइज हो गया विक्टिम इज इन कार्डियक अरेस्ट, स्टार्ट सीपीआर, एईडी आ गया, यू विल यूज द एईडी, बट दिस टाइम यू हैव टू वाइप द चेस्ट अ लिटिल बिट. इट शुड नॉट बी कंप्लीटली ड्राई. थोड़ा बहुत आपको क्या करना है? वाइप करना है एंड यू विल अप्लाई द पैड्स ओवर देयर. ओके, पेसमेकर पता है किसी को? पेसमेकर क्या होता है? What is pacemaker? What is the use of pacemaker? Okay, बोलो. Basically, pacemaker will deliver the shock to maintain the heart rate, right? So, अगर patient को pacemaker है, implanted pacemaker है, can you deliver the shock from the outside? आप shock दे सकते हो बाहर से? Yes, we can deliver the shock. But what you have to take care of, you are not going to apply the pad directly over the pacemaker. अभी आपका पेसमेकर काम नहीं कर रहा है, तभी तो विक्टिम कार्डियक अरेस्ट में गया है, राइट? तो सपोज करो आपको एक राउंड लंप दिखाई दे रहा है और या फिर आपके अटेंडेंट ने किसी ने हिस्ट्री दे दी कि पेशेंट को पेसमेकर है, तो आपको उस पार्ट को अवॉइड करते हुए कहीं भी आप पैड लगा के शॉक दे सकते हो. जिसने एसए नोड और एवी नोड बोला था वहां पर आपका शॉक डिलीवर होता है, उसका पेसमेकर से कोई लेना देना नहीं है. ठीक है, मतलब इस टर्म से रिलेट नहीं करेगा. ओके, सपोज करो पेशेंट को बहुत ज्यादा हैवी हेयरी चेस्ट है, तो पैड्स अच्छे से अटक पाएंगे नहीं, तो क्या होगा? शॉक अच्छे से डिलीवर नहीं होगा. सो व्हाट यू विल डू? तो क्या करोगे आप? सो व्हाट यू कैन डू इज, अभी आपकी एईडी की किट में, फर्स्ट एड किट में शेवर और क्लिपर भी होता है. यू विल शेव द एरिया फर्स्ट, जहां जहां आपको पैड लगाना है, यू विल अप्लाई द पैड. और वन मोर थिंग यू कैन डू इज, कुछ एईडी की किट में मोर देन 1 और मोर देन 2 पेयर ऑफ पैड्स भी होते हैं, तो आप क्या करोगे? इनको वैक्स की तरह यूज कर सकते हो. ठीक है, आप क्या करोगे? अच्छे से पैड्स लगाओगे. इफ इट इज स्टिल नॉट वर्किंग प्रॉपर्ली, एडी आपको बता देता है कि पैड्स आर नॉट अप्लाइड, प्लीज चेक द पैड्स प्लेसमेंट. ओके, तो आपको क्या करना है? थोड़ा फोर्स लगाना है. इफ इट इज स्टिल नॉट वर्किंग, टेक इट आउट फोर्सफुली सो दैट द हेयर्स कैन कम आउट. तो आप क्या करोगे? उसके बाद वहां पर दूसरे पैड्स लगा दो. सो दीज आर द सर्कमस्टांसेस जो आपको देखने को मिल सकते हैं whenever we are going to provide CPR or whenever we are going to deliver the shock by using AED. Clear to everyone? Is there any doubts? Any doubt you can ask, otherwise the discussion is over. और जिसको अगर compression करके देखने हैं, they can perform the compression. I'll tell you your compression are effective or not. Okay? किसी को compression करके देखने हैं? जिसको नींद आ रही है वो आ सकते हो. Any doubts? Is there any doubts or not? Okay. Thank you.
Thank you so much, sir, for the valued informative session. On
Now,
CPR.
Now, I'd like to invite Director, Amity Institute of Pharmacy, and Dr. Naveen Sharma to kindly felicitate Mr. Rajkumar Jaiswal, Mr. Rohan Sharma, and Mr. Dilip Sharma. Mr. Rajkumar Jaiswal, sir, please. Mr. Rohan Sharma. And Mr. Dilip Sharma. We'd also like to felicitate Mr. Gaurav Sharma and Mr. Rajiv Shukla, but as they are not here with us, I'd like to request either of the team members to kindly receive the felicitations on their behalf.
This brings us to the end of the proceedings of day 1. We hope that all the sessions conducted today are highly significant for each one of us and will surely enhance our knowledge.
Before leaving, everyone is expected to come tomorrow for the second day of the national conference.
Thank you. Have a nice day. Exactly. Everyone is requested to come again for tomorrow's session at sharp 10 a.m.
Where is the pointer? Pointer. Pointer किसको डालते हैं? Pointer कहाँ है? Pointer मैम तो नहीं है. Pointer कहाँ है? हेलो. अरे हाँ बोल रहा हूँ. अरे हाँ मैं बोल रहा हूँ. बोलता हूँ. पॉइंटर यार इधर देखो. मैंने इसलिए कहा भी था आप लोगों को ध्यान देना.
नहीं आपने बोला था वो मेरे पास
अरे नहीं उसके बाद दिया था ना जो अभी